Good morning, everyone, and welcome to the PNG Institute of Medical Research. Today, we're having our second virtual symposium, and we're so pleased that so many people have registered for this event and are joining us online. We're streaming live from Goroka, Goroka in the Eastern Highlands Province, and we know that we've got participants joining from all around the world as well as in Papua New Guinea. I think our last count is we had over 230 participants joining us. So we wish you a very warm welcome. Thank you so much. Today we're going to hear from many of our scientists, our researchers, and also our collaborators. The theme for today, for this symposium, is Innovation for Better Health. And you will hear many of the stories of the Institute's research programs. They're showing innovation from conceptualizing research to conducting research and then translating that research into improvements in healthcare services, program design, and also policies in Papua New Guinea and also beyond. So welcome to you all. We really encourage you to participate and interact with us during this virtual symposium. There is a chat function where you can note down your comments and questions, and we really want to use this time to interact and have discussion as well. Also, please, wherever you are, it'd be lovely to hear where you are. So if you could just put in the chat that you're joining us from wherever the country or around the world, that would be really great. So without further ado, I'm going to invite the Director of the Institute, Professor Willie Pomat, to make some opening remarks, and then we'll also hear from Professor John Kaldor from the Kirby Institute in Sydney. So thank you, Professor Pomat.
Good morning, everyone. It's good to have all of you with us this morning, and I'd like to welcome you all to this virtual symposium, which is on innovation for better health. And I hope that throughout the symposium, or throughout the next few hours, that we will get to see some of the innovations that the Papua New Guinea Institute of Medical Research has done and has been doing and is going to be doing into the future. So with that, I'd like to welcome everybody to this event and hope that you enjoy it. And as much as possible, if you have any comments that you want to put for us to answer, please do that. We have people who will be helping to relay your comments back to you. Now I give to John to say a few words as well.
As Pam mentioned, I'm from the Kirby Institute, UNSW, but the reason I'm speaking at the start of this symposium is because I'm also have the honour of being the co-chair of the Buttressing coalition to support the PNGIMR alongside Professor Willie Pomat, and our role in the Buttressing coalition, which is a partnership of many organisations from Australia and internationally, which provides support as needed for strategic areas of the PNGIMR's development. That's our role, and my role in that capacity is really to try and make that process as smooth as possible and ensure that our support is as effective as possible. This symposium is a great example of the sorts of innovation itself. It's, as Pam mentioned, the topic is innovation, but this symposium itself is innovation. It's innovative. And it is fantastic to see so many people joining in from around PNG, around Australia, and around the world. And this is the sorts of I guess if you can think of it as any positives from the pandemic, the idea that we can have these symposiums that bring so many people together to figure out actually how to make progress and to support the PNGIMR in one day, in a few hours. Thank you to all the participants and all the presenters, but also thank you to all of you who are joining online. And I wish all the best for this excellent seminar. Over back to you, Pam. Thank you.
At this juncture, we are just waiting to see if Professor Kevau is online. He isn't, so we'll continue on to our scientific program, and perhaps when Sir Isi joins us later on, we can give him a moment to make some remarks. So we're going to go straight into our first scientific session, and it's my great pleasure to introduce the chair of the session, who is Dr. Moses Laman, the Deputy Director for Science at the PNGIMR. Thank you, Dr. Laman.
Thank you, Pam, and hello, everyone. Welcome to our first session for this morning, the scientific program, and I'll be our chair for this morning. I'm Moses Laman. I head the Vector-borne diseases unit at the Papua New Guinea Institute of Medical Research. And I'm happy to be with you all this morning. Our session for this morning is innovation for implementation. And at the IMR in recent years, we've been conducting a lot of implementation research. And implementation research is really important for settings like ours. It's a developing country setting where many times we have good policies, but implementation of those policies continue to be a challenge. And it's not a unique challenge for Papua New Guinea. It's a challenge that many other developing countries continue to face. But when we talk about innovation, this does not always mean high tech. For our setting, this could be methods or ideas or products can contribute to better health, particularly in the public health space, where we continue to have, for us in this setting, we continue to have a lot of public health challenges, and these range from, malaria to otitis media to sexually transmitted infections. And so our presentations for this morning will reflect some of those innovations. And our first presenter will be Kilon. Kilon is a young researcher at the PNG Institute of Medical Research working at the Vector-Borne Diseases Unit, and he'll be presenting some of the acceptability and work that we've been conducting in Madang as part of the NatNat project. And we can do lots of clinical trials and field-based epidemiological studies and entomological studies, but what do the communities think? What do the communities think of some of the new products that are being rolled out? And so some of those acceptability work will be presented by Kilon, and how this can be translated to inform policy for better decision making. And then this will be followed by Celestine's talk, Celestine and Rita. Celestine is one of our senior scientific officers at the Institute. We are proud of her contribution in recent years. She's been instrumental to rebuilding the otitis media program of research at the Institute. Asked about some of this work, and now she plans to translate this program of work to inform policy and collaborations with the local provincial health authority, as well as the National Department of Health, and the work going forward into the future. So Celestine will be leading our second talk with Rita. And then our third presenter will be Professor Andrew Vallely and Pamela. They'll be talking about some of the innovative work. We are proud of this group's work in collaboration, IMI in collaboration with the Kirby Institute. They've been leading the way in doing some of the groundbreaking research on point of care testing. And so for sexually transmitted infections. And in this talk, they'll be talking about the HPV screen and treat for cervical cancer elimination. Cervical cancer continues to be a major problem for us in Papua New Guinea, and so their talk will highlight some of those translational research that they have been doing that can have a lot of public health importance for our setting. So without further delay, we will be going straight into our first presentation, second and third. Thank you.
I will be talking about the community and health systems acceptability of new vector control tools in Papua New Guinea. Papua New Guinea accounts for the vast majority of malaria cases in the South Pacific region, with the only vector control tool currently adapted into the national strategy being long-lasting insecticidal nets. Over the past 2 decades, there has been a significant reduction in the worldwide burden of malaria as a result of vector control methods such as elimination, indoor residential spraying or IRS, as well as increased availability of anti-malarial drugs and rapid diagnostic tests. In PNG, the key challenge of previous IRS trials was acceptability within the community. Recognizing that elimination alone will not lead to malaria elimination, the NatNat project is investigating the community and health systems acceptability of new VCTs such as IRS in PNG. The NatNat project has 4 core objectives, and I will be specifically focusing on the objective number 3, investigate the community and health system acceptability of new VCTs. We undertook mixed method research to provide evidence on the acceptability of IRS at the provincial, or district and community levels of the health system. These assessments focused on the feasibility and acceptability of implementation-ready VCTs, observation of current use of VCTs, behavioral relevant factors to the mosquito control. We used 3 main methods to collect data: semi-structured interviews, focus group discussion, and structured observation. For the semi-structured interview and focus group discussion, we used pervasive sampling, and structured observation was conducted alongside community leaders when recruited for in-depth interviews. The data collection was ongoing since August 2021, and the data was analyzed using thematic analysis assisted by NBVO12, and the analysis also used the acceptability of LK intervention framework. The quantitative data was analyzed using Excel. To the baseline preliminary findings, as you can see from the graph, IRS was widely accepted at the provincial level of the health system. With one of the district health officers said, there will always be some negative bounce back when we introduce new tools. We need to understand the perception and the acceptability of the community. From my perception, with the proper guidance and information, it can be accepted in communities if safety procedures are followed. And also, as you can see on the pie graph, they perceive IRS to be very effective, with only 11% deeming it to be ineffective. An important part of this acceptability study was gauging people's perceptions, past experience, concerns, and feelings towards the introduction of IRS. So overall, the majority of stakeholders at the district and provincial level perceive IRS to be very effective. As one of the community leaders said, it is good because it will kill more mosquitoes compared to LLIN. From experience in the past, DDT has somewhat affected animals and human beings. I understand IRS because of the awareness. Also, a chest leader said, I am concerned about my animals. Understand it's good to control mosquitoes. If there is more awareness, people will accept it. So lastly, this acceptability studies provided really beneficial insights from provinces and communities as to how best they suggest the rollout of new tools into their communities and environment. As one of the Deputy Director of Public Health said, we have past challenges to learn from. For successful implementation of vector control tools, we need proper surveys, training of human resources, and good awareness. IRS was then rolled out in November 2021, and 1 month following, we conducted the next round of the acceptability surveys to understand the impact of IRS, passive efficacy, and fit within the community. So in terms of impact on the burden of malaria, one of the community members said, after IRS, I have not seen any malaria in the community. The community highlighted that the success of IRS and community uptake is linked to good awareness, logistic support, and involvement of the community members. As one of the community members said, I have a lot of household items, so I prepared 2 days early to move the items outside and made it easy for them to spray. Adequate notice is also critical. As one of the community members said, we need advance notice to move household items, also to involve all community members and not just some people. So it was interesting to reflect on the passive efficacy of IRS with the community. Many community members commented on the reduction of mosquitoes and insects. For example, one community member mentioned, I personally like IRS. In the past, we complained about mosquitoes and other insects. Therefore, we are happy for the spray or IRS. However, it also became apparent that the community members' mosquito control behavior was also impacted by spraying, with only 67% of the informants still using a bed net following the spray of IRS. As one said, Before the IRS, we use mosquito nets, but after or now, we are not using LLIN. Another one said, we still use the mosquito nets because there are few mosquitoes during the night. We then went back to the two communities 6 months following IRS and undertook a series of interviews, focus groups, and observational assessment with the communities. So by this point, we were able to learn and hear about some of the long-term impacts that IRS was having on the community and reflect in more details around the influence on decision-making and unexpected benefits. So community members commonly felt IRS was effective at reducing insects and mosquitoes, with one participant saying, we had less mosquitoes, we were happy, some even sleep outside, but now they are coming back again. We saw very few in the 4th month and now they are plenty now. So it is interesting to reflect on the commonality amongst community members' perception around when mosquitoes have started to come back and how they perceive the health of their community during this time. So one of the key learning things that has evolved during this phase of the acceptability assessment is the influence on decision making and process for building consensus within a family unit. Awareness and community engagement have been absolutely critical factor here. One of the community member mentioned the information was very clear. It made the people happy. Very few people said no. We did an environmental control like cutting down grasses, raking leaves, setting fire, and then they came in and sprayed our houses. So through this process, the team had an opportunity to learn and reflect on the IRS trial that was undertaken in Brown River prior to this research study. Through this work, we were able to identify the importance of staging community engagement and the use of different communication materials. So lastly, there were some unexpected benefits that community described when talking about IRS, including health of the community more broadly. As one of the community members said, it was very nice. The people were happy because it's like one in a very long time. So through this acceptability survey, there has been many lessons learned that can apply to the introduction of new VCTs into routine policy and practice. So understanding the acceptability of novel VCTs is a priority for the introduction of new tools into policy, which is critical to achieve PNG's malaria control targets of malaria elimination by 2030. And this research has informed the National Malaria Control Program's National Strategic Objective to specifically the implementation of IRS trial plan for New Island Province and tailored community engagement and implementation to support communities prepare, understand, and adapt IRS is critical to the success of the program. Thanks very much. I will wrap up here.
Hello, my name is Celestine and I'm a research fellow at the PNG Institute of Medical Research based in Goroka. I have a background in microbiology and a research interest in acute respiratory infections and otitis media. Today, we're going to present preliminary results and observations from the study that we're doing here on otitis media in Goroka. So, otitis media refers to any form of inflammation and infection of the middle ear. OM can occur as a spectrum of disease, which can make it challenging to treat. But early detection, diagnosis, and treatment can prevent the condition of the ear from worsening. Otitis media, or OM, is an important cause of hearing loss. It can affect education and impact on social and emotional well-being of a person. The pictures to your right shows the different ear states. So the top picture shows a normal eardrum, which is characterized by a grayish pinkish color, and it's clear. You can see the eardrums shiny. The pictures below shows the different ear states relating to OM, which I'm not going to go into due to the interest of time. So from studies done in the Highlands, we know that children experience early burden of nasopharyngeal carriage with multiple species of bacteria, as early as birth, and this persists right throughout childhood. There's high rates of acute respiratory infection morbidity in this population. We know little on otitis media and hearing loss in the country. In a hospital-based study, 65% of ENT patients with hearing loss were due to otitis media. There's no data on microbial burden or etiology of OM in the country. There's a general lack of awareness of OM in the community. Many consider ear health as unimportant and will only seek health services several months or years after disease onset. And in PNG, disease is associated to superstitious belief. As below, I have two quotes from two patients that were seen at the ENT clinic when our nurses were training there at the Goroka Hospital. So one male, aged 28, with total perforation in both ears. When he was asked when he had experienced middle ear discharge, he said that he had chopped a wild banana plant where the musseli or the spirits lived, and the spirit boxed his ears. He slept with pain in his ear and woke up with blood and pus coming out of his ear the next morning. Another male ENT patient, aged about 50 years old, had loss of hearing in one ear and severe hearing loss in another ear, said that he had always experienced reduced hearing, and he thinks that he must have been born like that, or that when he was a baby, his mom must have hit him on the head hard over the ear to make him lose his hearing. So to address the lack of data on otitis media in the country, we did a study on the prevalence and etiology of OM among children attending urban clinics in Goroka. The study is a prospective cross-sectional clinic survey. So we are seeing children 15 years and younger from the Goroka town catchment area who attend clinic for sick or immunization visits. We also see healthy siblings of sick children as well. So our sample size is 500 children, our target sample size, and our study aims are to determine the proportion of children 15 years and younger with OM, determine the risk factors associated with OM, determine microbiology of visible middle ear discharge, compare the microbiology of nasopharynx between children with OM and those without OM, and to determine the pneumococcal serotypes associated with suppurative otitis media post-PCV 13 introduction. So PCV 13 was introduced into PNG childhood immunization schedule in 2014. So these are the study procedures. So in brief, we collect information on diagnosis, demographic and risk factor data, informed consent, and then we collect general information on general ear health and ear complaint. We do clinical examination using otoscopy, videotoscopy, and tympanometry in both ears. And these data are then shared with audiologists in Perth through the REDCap database. And through the study, we are using telehealth to provide diagnosis remotely. And we use the PNG guidelines to manage OM. And where appropriate, we use the Australian guidelines. So we collect a nasopharyngeal swab from all the children in the study and an ear discharge swab when ear discharge is present.
Hi everyone, my name is Rita. I'm the research nurse for the otitis media study in Goroka. I'm going to present to you two of the case studies which I've come across during this study. So case study 1 is about patient A. He's male of 6 years old. He was presented with complaint of dislocation of joint. However, during our informed consent process, we've discovered that the child has otitis media or middle ear discharge as well through mom. The mom told us that she thought otitis media wasn't important enough to report because she had experienced this 4 years ago when her son was 2 years old. She brought him to hospital or clinic and was told by the clinicians to do ear toileting alone and no antibiotics were given back then. She thought that otitis media has no treatment or whatsoever. But during our observation, we've discovered that her son has subtotal perf on both of her tympanic membrane and has very large hole, more than 50%. And we've also discovered that the child is behind speech milestone. The mom has concern because she thought that her son was dumb. But now that she knows that otitis media can cause hearing loss, she was relieved and she wanted us to treat her son for the otitis media as well. Our next case is patient B. She's a female of 10 years old. She came in with a complaint of middle ear discharge. She had middle ear discharge like when she was 4. Her parents sought different specialist attention, but don't know where or the pathways. So they gave up along the way. However, after 6 years, she came in and we've discovered that both of her tympanic membrane or eardrum are gone. And we've treated her with antibiotics for 6 weeks and referred her up to ENT for hearing test. The test shows that she has moderate to severe hearing loss. And that's the reason why she's dropped out of school. And all of this wouldn't happen if the pathway was made clearer at the first attempt. Okay, here are some of the things we've saw in the clinic. Otitis media or middle ear discharge is normalized. It's seen as normal, like it's not seen as disease. Nearly every patient or 90% of the patient that we've seen have no or very little knowledge of link between otitis media and hearing loss. Most of the children present with other complaint and not the otitis media, but during examination, we found out that they had otitis media as well. Clinics lack basic equipments like otoscope and tympanometer to detect middle ear infection. Otitis media is noticed when there is obvious middle ear discharge or complications, as you can see from our live images. These are some of the complications that most parents tend to bring their children in for. Clinicians need to do ear training to detect otitis media early.
This pie chart shows overall tympanometry results from 208 children. From 208 children, 27% of the kids had normal ears. 45% of children had otitis media with effusion or glue ear, which is indicative of fluid behind the middle ear. 18% had discharging ears, and 20% had perforated eardrums or hole in the ear. So in our population, we've seen high rates of OM, and this is higher than WHO's more than 4% prevalence of CSOM, signifying a public health concern. There's a lack of trained ear specialists and clinicians in the country, and there's a lack of ear and hearing health services and pathways to access these services. There's also a lack of awareness in the general public about OM and the link with hearing loss. We'd like to thank our study participants and the parents and guardians from our studies, the Goroka Hospital ENT nurses, our nurse Kuhole and Sister Goina. Thank our funders, West Farmer Center of Vaccines and Infectious Diseases, and Center of Research Excellence in Ear and Hearing Health. Thank you.
Good morning again, everyone. So it's my great pleasure to introduce myself and Professor Andrew Vallely from the Kirby Institute and also the IMR. And we're going to, in this presentation, do a bit of a double act and present and try to summarize a massive body of work that the IMR has been involved with the partnership and support of the Kirby Institute and also other partners. And so this whole work has culminated now in some exciting developments in the space, looking at finally this agenda of eliminating cervical cancer in the country. So I am going to start. So the first part of this presentation will really be a summary of what we've done to date, and then Professor Vallely will talk about the exciting next steps going forward. So in the last 10 years, the PNGIMR and the University of New South Wales, the Kirby Institute in Sydney, have had this collaborative program that has been designed to evaluate point of care testing for HPV, so that's human papillomavirus, high-risk human papillomavirus, and then for the purpose of identifying women who are high-risk positive and to then provide cervical ablation for treatment. So essentially a one-stop see, treat, test and treat service for women. So working with the PNG Obs and Gynae Society in Papua New Guinea, the PNG Cancer Foundation, national and provincial health authorities, community stakeholders and other partners, our shared goal in this undertaking has been to identify the most effective, acceptable, efficient, cost-effective and scalable screening model for Papua New Guinea. So in this diagram, you'll see a woman comes in, she's given a swab, she has a self-collected, she takes a self-collected vaginal swab. That swab is then tested on a GeneX platform at point of care. The test takes less than 1 hour. And so within that time, we're able to know whether she's positive for a high-risk HPV infection, and then treatment can be provided in that one consultation. So I'm just sharing one of the first papers we published, which essentially demonstrated that point of care HPV testing of self-collected vaginal specimens was equivalent to a clinician-collected cervical specimen for, first of all, the detection of HPV, high-risk HPV, and then also was able to predict or detect underlying cervical precancer and cancer. So that first work we published in early 2016, and then based on that, we looked at all the other different kind of requirements of how this could be, assembling the data to show that this was a robust test and this was something that could actually be scalable in Papua New Guinea. So this work was recently published in Lancet Global Health, and essentially what we were able to show in this first field trial was that an integrated point of care HPV DNA screen and treat model, we were able to demonstrate that this model of collecting self-collected specimens had high sensitivity, the sensitivity of 90%, high specificity, of 89%, a PPV and NPV of 35% and 99% for the detection and treatment of cervical precancer. And this was a highly acceptable, cost-effective model that is suitable for a setting like Papua New Guinea, suitable for routine delivery, and actually can be scaled at primary healthcare facilities. This particular work was led by Dr. Nguyen from Sydney Uni, but as part of this larger collaboration. And in this particular paper shows that this strategy of point of care HPV screening and treating was highly cost effective. So everyone talks about innovation, but can we actually, is this something that we can do, and is this something that we can actually cost, and is it sustainable? So it was highly cost effective when you compare it to other models such as pap smear or visual inspection with acetic acid or other models similar. And the second thing that we were able to demonstrate in this work and then in this paper is that we have the potential to make a significant population impact if delivered at scale in Papua New Guinea. So if we were to screen 70% of age-eligible women at least twice in their lifetime, we would have the capacity to reduce cervical cancer incidence and mortality in Papua New Guinea by 50%. Now that's huge, and that's even in the absence of an effective HPV vaccine. So testing and screening and then being able to treat, we've been able to demonstrate in this body of work that is something that Papua New Guinea can do, and it would have a huge impact on the number of women that are being diagnosed with cervical cancer in this country. So at this point, I'm going to pass on to Professor Vallely. Thanks, Andrew, to deliver the second part of the talk.
Thanks so much, Pam. Yeah, it feels like Pam and I have been doing a bit of a double act for probably half my career. So this is, it's a real privilege to be able to share these findings and where we've gone with these findings, and to share this stage with you. So just a little bit now on where we've gone with some of these findings. So in the last 2 to 3 years, we've been working very closely and continue to work very closely with our partners in PNG in Australia to translate the findings that Pam has just summarised into public health action, both in PNG and in other countries in our region. And key to the success here and our success so far in this translation has been the paradigm shift that's been going on in the background of the context and the shift in global policy from cervical cancer control to elimination. And this shift itself has been driven by robust evidence from people like ourselves and many others around the world, and from a variety of clinical intervention research, epidemiological and economic modeling, demonstrating the effectiveness and impact of the tools that we already have available to us. And this culminated in November 2020 in the launch of the WHO Global Strategy on the Elimination of Cervical Cancer as a Public Health Problem. And the strategy puts forward 3 key coverage targets to be achieved by 2030 that would place countries firmly on a path towards elimination of cervical cancer. And these are the so-called 90-70-90 targets. So 90% of girls fully vaccinated by age 15, 70% of age-eligible women screened at least twice in their lifetime, and 90% of all those with pre-cancer or invasive disease effectively managed. So complementing the global elimination agenda, updated and revised WHO screening and treatment guidelines were released in July last year. And we were very, very fortunate. We have a fantastically dynamic and committed and dedicated national technical working group in PNG on cervical cancer, comprehensive cervical cancer control and elimination, convened by the National Department of Health and the ONG Society. And together we looked at these guidelines, we looked at the locally generated evidence that Pam has just summarized and put these together and developed new guidelines, which we're just summarizing here, one of the key algorithms, pathways in those guidelines. Presented those to NDOH and to the National Technical Working Group, and these were endorsed on the 6th of December as the primary recommended screening modality in PNG to be HPV screen and treat, exactly along the lines as established and validated in our earlier work. Around the same time, this is a very exciting and dynamic field. Discussions around HPV screen and treat have been progressing in PNG, but we've also been progressing our discussions in the region, looking for further funding to take forward not only our research agenda, but very importantly, to drive the whole development agenda to support countries in implementing these innovations and putting these into practice. And we were, the PNGIMR and our collaborative group played a lead role in securing this a landmark regional program on cervical cancer elimination towards the end of last year. And this is a culmination of philanthropic funding, industry partner donations, development partner and government contributions, and will support activities in both Western Highlands Province in Papua New Guinea and also across the whole of Vanuatu, and will impact the lives of 120,000 girls and women across both of those settings. And the shared vision is that this foundational investment will drive elimination both across PNG and across the region. And just in brief, the initial focus in Papua New Guinea will be in Western Highlands, but this is intended to be a start. And the program is being led by Jane Holden, Dr. Powers, Rita, and colleagues at Western Highlands. And I just wanted to note that they and their team have been really inspirational leaders and partners, and they were the first health authority, to my knowledge, in the whole of the Pacific to actually embrace the whole elimination agenda, even around the time before the formal announcement by WHO. And here we're proposing a hub and spoke model to ensure that from the established World Women Clinic, we are able to extend services for women who most at need, particularly those in remote and rural communities, to ensure these women are not left behind as we advance towards elimination. Complementary work is being funded again through our collaboration. We've been successful in gaining separate funding through the Global Alliance for Chronic Disease to our collaborative group that will allow us to advance the agenda in Madang. And this builds on earlier work and the dedication, again, the leadership of Dr. John Bogner, Dr. Paula Au, and their team in Madang, and the incredible work that they have been doing together with us as part of those earlier field trials and this earlier work. And this GACD grant provides us with funding for implementation research to help us understand how best. So I just want to finally acknowledge a huge number of organizations, partners and colleagues and friends, and particularly the women and the communities and the families that have engaged and supported in our work. And thank you all so much for listening to our presentation today.
Thank you, Andrew and Pamela and all the presenters that have presented so far. Before we go to the next session, I would like to take this opportunity to welcome Professor Kevau to say a few words before Willie comes up. Professor Kevau is the chairman of the PNG Institute of Medical Research IMR Council. He's been instrumental in helping us to rebuild the institute over the last 6-7 years, and he needs no introduction. Welcome, Stacey.
Thank you very much, and welcome you all. Good morning. In Motu, we say Davanamona to all of you. I welcome you all wherever you are. Your participation in the PNGIMR virtual symposium is highly appreciated. This is on innovation for better health. Slightly out of the clinical language dictionary, but that's okay for me. So I acknowledge all of you. I'm very proud to be part of the PNGIMR and all that's been happening in PNGIMR, and in the last several years, you've gone to this kind of conference, which is very nice. The last presentation is also very impressive. So I take this opportunity to thank each and every one of you in Papua New Guinea, Australia, all over the world for your participation in this very important occasion. And last and then, all of you, PNGIMR administration, the director, deputy director, and everybody, you are all to be congratulated. Every time I think about PNGIMR, I'm very proud that IMR was born before Papua New Guinea's independence. I was at the National Parliament Prime Minister election, and I realized, as things were evolving in a rather slow way, I realized that PNGIMR was born in 1968, and Papua New Guinea was born in 1975. So I was very impressed that we are older than Papua New Guinea independence. And I'm very proud that all of you all over the world have made this contribution to help us in this wonderful country called Papua New Guinea. And I wish you all the very best, and I'm sure that your continuing support will help us in every way. And all the presentations that have been made so far have impressed me a lot, and we'll carry on with all your support. We should be thankful to all of you. I'll ask my village people to make a song for your contribution to the way we look after this country. Have a happy meeting and keep going. Thank you for your attention. Sorry about this. Bye.
Thank you for your comments. We really appreciate it. We have a lot of questions that came up in the first sessions, but due to time factor, we won't be able to answer all of them. So we will move straight to Director of PNGIMR, Professor William Pomat, now in his talk in the next coming presentation. Thank you, Willie.
Firstly, before I go into my presentation, I'd like to mention that an apology from the Health Secretary. He's not able to make it today because for many of you who are following the politics in Papua New Guinea, you will have known that the new Prime Minister has been voted, and as the Secretary, he has to be there to deal with the political side of talking with the new Health Minister and all of that. Plus, he also has an important meeting to do with medical supplies. So he couldn't make it this morning, so that's why we went straight into the sessions. Anyway, this morning I'm going to talk to you a little bit about the work that we are doing at the Institute. And I think most of you already know some of this, and some of this work arises from the innovations that many of you are involved in and have been involved in and will continue to be involved in. So firstly, in memoriam of all those who have passed in the last 12 months, and I'd like to particularly mention late Grand Chief Sir Michael Sumare, who was a very big supporter of the Institute from when the Institute started all the way to right now, and many of us are now in the job here. Also, two important icons of the health sector, the late Professor Evelyn Lavu and the late Dr. Paison Dakulala, both of them were big icons and big shoulders for which the health sector stands on. At the Institute, we've lost a few staff. They are listed there. The late Robert Rusiat, Richard Buffo, Ahmed Gihi Gupa, and Jesse Kara, sorry. And because this is August, it also marks the month when 5 of our scientists went missing 11 years ago. So I thought I'd just mention that thing. So IMR has had a lot of impact, and there's a lot of work that you can come to the Institute and read through. There's monographs, but I'm highlighting 4 areas: the pneumococcal, leading studies in pneumococcal area that, in pneumonia, that led to the introduction of both the Haemophilus influenzae and the pneumococcal vaccines, plus the measles vaccines. Studies over the last 50 years have done that. Also, there's a lot of work on lymphatic filariasis that has led to mass drug administration that is currently being conducted in East New Britain and soon to be conducted in West New Britain. There's a lot of studies also on malaria that there's a lot of innovations on. And many of you continue to be involved, and we're very happy for your involvement there. And as well as that, some of the earliest work was on Kuru, that was only particularly in a specific population here in the Eastern Highlands province. And a lot of that has led to new knowledge that has helped us as we go along. So we're very thankful to Professor Michael Alpers, Carlton, and others who worked in this area. And a lot of this work can be seen in Michael's work in a PNG Medical Journal in 1999. In the last 5 years, I'm only putting in 3 areas that we have done a lot in, and mass drug administration, or the elimination of elephantiasis, if you like, is the major one. And a lot of work done through the Institute has now led to implementation of mass drug administration in a couple of provinces in PNG, and hopefully throughout PNG soon. Also, the studies that we are conducting has led to shown that there's high rates of HIV drug resistance, and hopefully this information will lead to changes in the first-line treatment for HIV. And as well as that, our team in the entomology department showed to the world that the impact of increasing malaria incidents are partly due to bed nets that were not adequately, they had decreasing bioefficacy. So all this work in the last 5 years have been really innovative. So essentially, many of you already know that the Institute was established in 1968. We just had a council chairman. We have a 7-member council membership, and about 60% of the grants that we receive come from the government. At the present time, there are about 350 staff. That fluctuates with the number of projects that we have. And sorry, Andrew, I didn't put the dot for Mount Hagen, but these are the areas that we currently work in. And Mount Hagen also is currently very important for our activities as well. You can see many of you have been here will know that we work in the East Pacific province, in Medang province, have set up in East New Britain, as well as now there's a lot of work going on in Port Moresby, and a bit of work going on in Milne Bay province. At the Institute, we have research capacity as well as laboratory capacity. And in the recent few years, we've had all these young ladies, as well as a few young men as well, that are coming on who have gained their PhDs and are returning to Papua New Guinea to help us to conduct research into the health problems affecting Papua New Guineans. So we are very grateful for past leadership that has led to capacity building for our future research leaders. We hope that we are going to see a few more research leaders returning from PhD studies, and thank you very much to many of you who are helping to supervise a lot of our rising stars who will be coming back and leading research here. As well as that, we've got laboratory capacity here in Goroka, in Medang, and hopefully we build up the Port Moresby laboratory as well. This is our management structure, and essentially we've got 2 deputy directorship, one for the sciences and one for the corporate affairs or administration, and the administration ensures that all the research activities are done well. We have 5 research units, and you can see from those 5 research units, We have infection immunity, sexual and reproductive health unit, population health and demography, and vector-borne, for research, vector-borne disease unit. And I will go into details about the programs that each of these units runs. So the vector-borne disease is our largest unit, has a diverse method of field clinical trials, sentinel site surveillance, mosquito surveillance as well as population, as well as genomics analysis, and probably attracts quite a lot of grants for the institute, from funders including the Gates Foundation, NIH, Wellcome Trust, and National Health and Medical Research Council. Currently, the vector-borne disease unit is looking at consolidating all the genomic surveillance, and we've got a PhD student in Melbourne who hopefully will come back and establish or continue to establish that here in Papua New Guinea. The use of serology for testing various pathogens, including malaria parasites, different strategies to control vivax malaria, evaluation of long-term efficacy of single-dose triple drug for elimination of LF, malaria in pregnancy, and as well as testing innovation in our entomology, testing innovative environment control for mosquitoes. And the study is aptly called NatNat. In our reproductive health unit, which is our second largest unit, runs laboratory, clinical, and social science. And you've already heard previously from Pamela and Andrew about some of the work that they are doing. Excuse me. Sorry, nature took its course. We currently have, first point of care testing and treatment for cervical cancer, HIV, and other sexually transmitted infection. Research on COVID-19, which hopefully will be out soon, and spread of false misinformation through social media, experience of HIV and youth during COVID, which is funded through the Buttressing Coalition, and studies on zoonotic, as well as social determinants of TB. In the infection unit, which is currently the National Influenza Center, and also the unit where we conduct the testing for SARS-CoV-2 or COVID-19 for Papua New Guinea. And at the moment, we're starting up monkeypox diagnosis for Papua New Guinea as well. They're also conducting research surveillance on respiratory and diarrheal disease, studies on antibiotic resistance on a range of pathogens, and innovation in the prevention of severe illness in infants through the use of probiotics. You heard earlier in the earlier session where Celestine talked about ear infection. That's also through this unit, as well as there's a study on the host determinants of immunity to infectious disease like pneumonia. In the population health and demography unit, we have malaria surveillance as well. So the monitoring and evaluation of the national malaria control is conducted through this unit. We have household demographic surveillance in rural and urban areas in the 4 regions of Papua New Guinea, as well as currently we are starting to focus on malnutrition, stunting, lifestyle disease, food security or food insecurity, and also beginning to look into the focus on health economics. This is some of the COVID-19 research that we are currently our scientists are working on. This is through a small grant that the Buttressing Coalition were able to provide money for, and so our scientists have applied for that, and these small grants are helping our scientists to build their careers, but also provide the evidence for them to apply for bigger grants. This is our corporate plan for the next 5 years. So our vision is to be the leading center of excellence in public health and medical research, and lead the acceleration. The purpose is to lead the acceleration of innovation to improve health and well-being of the population through research. And within the corporate plan, we have institutional, there are 5 pillars: the institutional excellence, investment in core research, research innovation, leadership in science and evidence-based policy, as well as partnership. And from that, I think partnership is the most important one. All of you are our partners, and we welcome you to come and help us to conduct research into the health problems of Papua New Guineans. Some of the infrastructure development that we've had over the last 12 months, on the very left, we're now constructing a new laboratory in Madang. The groundwork has begun. We're thankful to the government of Papua New Guinea, who has finally provided funding to build this world-class laboratory at Yomba, so that for those of you who know and love Yagaum very well, unfortunately, we are moving down to Yomba. So hopefully in the next 2 years, you can come and see us and see the new building that will be ready. At the top, the two top pictures represent where the NatNat project will be conducting some of the research in, and this is at GUM, also in Medang. So hopefully we will open this facility very soon, where all the mosquitoes from Yagaum will be brought here to be looked after, as well as to conduct various experiments on different methods of preventing mosquitoes from biting human beings. At the bottom, we've got renovations currently being conducted in Port Moresby. The picture with the green building is our renovation currently in Port Moresby, as well, and on the right with the orange house and its interior, it's our infrastructure renovation going on in Maprik. So those of you who've been to Maprik will now go and hopefully live in a building house that has a lot less termite infestation. And probably part of this conversation we'll think about innovations to also prevent termites from attacking buildings. So in saying thank you, I'd like to thank the following: Tony Oakley from University of Wollongong, Holger from Menzies, Fiona Russell from University of Melbourne and MCRI, Denise Doolan from JCU, Celestine at IMR, James Beeson from Burnett, Michaela from Kirby and PNGIMR, Maxine from JCU, as well as Jeff Warner. Thank you very much for helping to facilitate this symposium. Also, I want to thank the Buttressing Coalition for the financial and collegial support for this symposium, as well as for ensuring that some of the infrastructures that we're building go ahead. I'd like to also thank all the presenters that have gone before me, as well as those who are coming after me on the presentation they'll be giving, and thank our IT guys. We always complain about them, but they've done a marvelous job, as well as the media team. Thank you, Dean and webcast team, for allowing us to be virtually able to reach everybody. The Department of Health would like to thank you very much, as well as all the study participants, communities, healthcare workers that help us. EMTASO, thank you very much.
Thanks. Thank you, Professor Pomat. We are going to cross over for a spotlight feature, and it's my great pleasure to introduce the spotlight, which focuses on the work of Dr. Alice Mengi, who's a clinical research fellow in the vector-borne unit of the IMR. Thank you.
Hi, I'm Dr. Alice Mengi from PNGIMR Medang. I joined PNGIMR one-time study in 2016 October as a research registrar, and in 2019 I was given an opportunity to do a Masters of Medical Science through PNG. My project, I look into identifying high-risk newborn in Papua New Guinea. Low birth weight and preterm birth are considered high risk and accounts for majority of poor outcome, including early neonatal death and disability in children. They also contribute to high neonatal infant and child mortality. Foodland studies done in Africa and Asian countries show that foodland can be an alternative tool in identifying low birth weight and preterm babies. However, all the studies were confined in health facility, very few with ultrasound reference standard, and no studies done in Pacific country, including Papua New Guinea. So we developed a new food study as a sub-study to one-time study, where all women enrolled in one-time study had an ultrasound assessment at enrollment. All babies from these mothers who enrolled into neo food study had a birth weight within 72 hours and was in either at the health facility or in the community. So we aim to determine the foodland cutoff, identifying the high-risk low birth weight and preterm birth, and we also aim to assess if trained volunteers can accurately assess food length and identify high-risk babies in the community. To do that, we develop a simple tool to measure the food length with all the items readily available in the village or community setting. This is a 15 centimeter ruler stuck onto a half cut box. The base is at 0, where the heel is, and we measure the foot length at the tip of the hallux. 342 babies participated, 21% were low birth weight, and 8.8% were preterm birth. All babies that are high risk preterm birth and low birth weight were correctly identified at the foot length cutoff less than 7.7 centimeter. We also compare volunteer foot length with researcher foot length with a blend Altman plot that showed good concordance. However, the difference in the ranges of measurement was just over a centimeter, indicating that volunteers would need more than a half-day training. In all, foot length is a good proxy in identifying high-risk, low birth weight and preterm birth babies in community by trained volunteers with regular training. This would help in immediately identifying these high-risk preterm and low birth weight babies and refer them to health facility for proper treatment and care to improve their survival chances and to reduce neonatal infant and child mortality, contributing to the Sustainable Development Goal 3. To conclude, I would like to thank my supervisors, parents of 342 babies participated, the volunteers, and the one-time staff. Thank you.
Hi, I am Dr. Melissa Newendorf. I am a research fellow in the Sexual and Reproductive Health Unit here at the PNGIMR. And it's my great pleasure to chair a session this morning on our social research work in public health. Just reflecting on what our director has talked about, Professor Pomat, and also Professor Kevau, I think what's really apt is that in innovating for the future, we are reflective of our past. We're also taking stock of what's happening now, of our present. And certainly the presentations this morning have been a great example of that, of what's happening in the PNGIMR now in planning for our future work. So this session will provide a short snapshot into the practice of social research in PNG, as told by Papua New Guinean researchers working in the space of sexual and reproductive health. Much of our social science research work is influenced by Indigenous and decolonizing methodologies, in principle and in practice. As such, our teams aim to promote and to recognize each member has strengths that contribute to the outputs of research and to broader conversations about health and people in PNG beyond the very important clinical and lab work that we do. The presenters this morning are a true reflection of this frame. And just to give you a little bit of an understanding of what they'll be talking about, some of our broader messages in this session are that social science perspectives can be translational, particularly when used as a tool for exploration toward understanding specific public health issues, health concerns, and also strengths and opportunities. And secondly, the first step in decolonizing research methodologies is by accepting the challenge that is set before us with research as Papua New Guinean researchers in PNG. Through developing skills, deepening experience and knowledge, and contributing through local understanding, being supported and in support of equitable research partnerships. As a little bit of background, the work of the social and behavioural section within the Sexual and Reproductive Health Unit builds on decades of formative work, including in the area of HIV, in gender, in maternal and child health, in society and human behaviour, and more recently in the areas of TB, malaria, and COVID research. The expertise of the section includes both qualitative and quantitative methods, and more recently integrating new technologies, which our first presenter will be speaking on. Covering all regions of Papua New Guinea, from urban to remote and rural settings, with gendered approaches. While we've got numerous publications and manuscripts and have contributed to books and book chapters, project reports, and also advocacy when and where appropriate, there's still a lot more work to do in terms of what social research can contribute to public health. The continued work of the section provides insight into matters of social, cultural, and moral significance, to attitudes, behaviours, understanding, and knowledge around identified public health issues. Our first presenter, Ms. Agnes Mek, has at least 15 years of social research experience and several first and co-authored papers. This morning, she will be talking to us about the importance of participatory methods and the use of new technologies in social research. Our second presenter this morning is Mr. Herrick Aino, who has up to 20 years of social experience, social field research experience as a field officer and now contributing to academic authorship and also program coordination. Herrick will talk about previous gender research that he has been involved in the unit, and also a current project that focuses on young people in pregnancy. Our final presenter today is going to be Mr. John Cohen, who has 5 years of social research experience. John will be talking to us about his research journey, focusing on the process of developing in the space that he has been placed.
Thank you, Nal. Good morning, everyone. My name is Agnes Mek, a social scientist from Jiwaka province in the highlands of Papua New Guinea. My presentation today is on decolonizing research from research to researcher through images and storytelling. What does colonizing research mean? It means different things to different people because of our positions, based on ethnicity, citizenship, and education. But it also means being a woman, a mother, and from a tribe. It allows me to share my stories as a Jiwakan woman, a social researcher, to share my stories working amongst the multicultural societies of Papua New Guinea and international academics by bringing to the forefront the critical reflections of those living on the margins through words and images that have deeper meanings and insights. For example, we have got words such as fire rise, caliphate, dinner marriage. These words may be meaningless, but they have got deeper meanings and titles. Experiences of Polynesian indigenous researcher. I struggle between my Western trainings and conducting research among my communities, that is whether to uphold the research ethical practices or modify and adapt to the local context without losing the focus of the research topic. Sometimes I become disconnected between the demands of research conducts and local realities encountered, given the complex PNG cultures and geographical conditions. So it is quite challenging and my role becomes blurred. Decolonizing Western scholarship in PNG. In Social and Behavioral Research Unit, we integrate contemporary Western approaches such as arts-based methodologies of participatory action research, which I find have important elements of decolonizing indigenous research and practice. They provide equity of subjects, involvement, and participation to become active researchers, as shown repeatedly in our data. Under the mentorship of international partners, I have published as best author and co-authored a number of reports and films which Melissa had mentioned. One of the methods that we have integrated in our research recently is called photo voice research method. Photo voice is a creative visual method which involves the participants being trained and given cameras to document, write, or record an experience or an issue that affects their health and well-being. This is an approach extensively used in our more recent studies. For example, the WHO COVID-19 study. The goals of Photoways is to enable people to promote critical dialogue and knowledge to reach and influence policy and decision makers. The quote there, what the experts think is important may not match what the people at the grassroots think is important. And that's from Wang and Redwood Jones. In conclusion, it is important to understand that we as researchers are links and voices representing our people, their daily lives, and normal and ordinary words, actions, and images have significant meanings. This extract is from a poem by Tamara Iga, a 12-year-old girl, summarizes my presentation. The title is Endurance of the West. They arrived and started controlling. We were aware of our captive future. We were unaware of our captive future, trying to preserve our carefree, colorful culture. Do not be ashamed of who you are. Embrace your unique country and its colors. Racism should no longer be a rule, and we're making it come true. Thank you.
So we're just going to cross over to Herrick Aino, who's our second presenter today. And as I mentioned, Mr. Herrick Aino is a senior social researcher in the Sexual and Reproductive Health Unit, and he'll be talking a bit about gender work in our SRHU unit.
I am Herrick Aino, and I have been working with the PNG Institute of Medical Research for 20 years now, and involved in many social and behavioral research. Again, I am a senior social researcher and currently coordinating the adolescent teenage pregnancy study. Over the years that I have worked at the Institute and the studies that I have been involved in, which all were social and behavioral, with focus on HIV, sexually transmitted infection, sexual and reproductive health. And some of the more prominent studies that I was involved in include penile cupping and male circumcision, social impact of ART therapies, research among male and female sex workers, and people with diverse sexuality, as they would like to be referred to in Papua New Guinea, transgender women, gay, and MSM. I was also part of the team that took part in a rapid assessment of criminal law, HIV, sex work, and male-to-male sex in Papua New Guinea. Another big study that I was a part of was the mass community study that mapped how individual communities. Yeah, with the various projects or research projects that I've worked with, gender has been a big part of those researches. And they include understanding the gender dynamics that affect health and lives of people, the health disparities that exist between men and women, social processes that make the health needs of men, women, and men with diverse sexuality differ or vary, and also the knowledge gaps between the different genders that exist. Also, the gender diversity and the gender variance that exist in PNG is also explored, including understanding gender, women, gay men, and men with MDS. Gender rights are also focus of the researchers that we have taken on over the years. Presently, I coordinate the adolescent pregnancy study. This study came about because of the adverse outcome associated with pregnancy among the young women, and remains a major health challenge and policy priority in many low and middle income countries, including PNG. Also, limited attention has been given to young men or boys' experience of pregnancy, and there is little to engage young men in efforts to reduce harm associated with pregnancy at a young age. This is important as gender dynamics are central to young people's relational experiences of conception, abortion, childbirth, and parenting. The study is a qualitative one and was carried out in 3 sites, representing urban, peri-urban, and rural settings in Papua New Guinea. 72 interviews were conducted with young people aged 15 to 24. Currently, all the service structured or the interviews have been done, and the visual method of photo voice is still pending and should be done soon or later this year. From this study, some findings have already emerged, and these findings have been put together to contribute to a book as a chapter, which I am leading. And some of the findings include tension between family and community expectation that such young men should not be sexually active prior to marriage. Young men involvement in sexual activities before marriage is highlighted. Also, circumstances that inhibit sexual practices that prevent pregnancy is also captured. And then the agentic practice, in particular relationship aimed at preventing pregnancy. My takeaway message is that the work I've done highlights how gender is conceptualized in PNG society. Regional differences such as being from the Highlands contributes to how I as a researcher understand gender and how this understanding can grow based on the social research that I do. I acknowledge our partners, Kirby Institute, UNSW, the communities of Mount Hagen, Barne, and Lay, where the study was carried in, and of course the field team and the support team at PNGIMR. Thank you.
Just to again introduce our third presenter, Mr. John McCohen will be speaking about his research journey from when he first started at the PNGIMR up until today.
Thanks, Larissa, for the introduction, and thank you, Eric and Agnes, for your presentation. My name is John Cohen, and I am a social researcher here at the PNG Institute of Medical Research, attached with the Sexual and Reproductive Health Unit. And I will be talking about my journey as a social researcher. I have joined the Institute of Medical Research back in 2017 as a data entry clerk, and I was basically doing the data processing part of the work at the Sexual and Reproductive Health Unit with other data processing staff members. And I was basically doing transcribing, translating, and editing transcripts all across the different studies being undertaken by social and behavioral research unit, that is sexual and reproductive health. And at the moment, I'm also doing this apart from other duties. As a data processor, I see that the data processing is very, very important and plays an integral part in social research work because most of the studies undertaken by the unit with regards to in-depth interviews, qualitative interviews, and focus group discussions for the voice are most of them, almost 95% of them are done in Tokpisin, which is the common language spoken throughout the country. So as data processors, we make sure that transcripts are transcribed appropriately and translations are done properly, so as editing to make it easy for coding and analysis. As a field officer, I was first of all introduced to the field as an observer, where I was basically taking field notes, sitting in with the senior staff members, conducting qualitative interviews, focus group discussions, and photo voice, where I've learned a lot by being an observer out in the field. And thanks also to the senior staff members and the project coordinators who have been by my side, helping me, telling me what to do, what not to do, how to go about conducting interviews. And most importantly, I've come to learn the importance of field work, where networking is very, very important. And we as field officers, we do out in the field means a lot because it helps us to collect quality data, and communication with our partners, stakeholders, the study participants, people on the ground, plays a lot of role, significance in the data collection process. With regard to interviews, I've been given a chance to conduct interviews with under the supervision of my project coordinator, and also with some senior staff members on the site, where it has also helped me in my research work. Currently, at the moment, I am leading the TB study team. I'm taking over from one of our colleagues who has left us, and I'm managing the TB data and also coordinating and organizing of planning fieldwork, which we're supposed to be going out into the field to do the final part of the study, which is the for the voice training of session, and also to disseminate the preliminary findings to the stakeholders and the study participants or the wider community. But due to the election violence and stuff, we have decided to defer the field trip probably to the end of this month. And the aim of the TB study is to investigate the social cultural beliefs and the behaviors that sustain and enhance the transmission of TB in PNG, and assess the acceptability and accessibility of current TB interventions for TB control in PNG. I've been engaged with the TB study. I've also taken part in the writing part of it, where so far we have published 2 research articles already, as you can see on the screen there, with the names of the other co-authors as well. The first one is exploring tuberculosis risk in Papua New Guinea hotspots, and the second one is on beyond TB patient delay and navigating structural health system barriers and timely care and treatment in high burden setting in PNG. And all these are done, the writings are based on the data being collected specifically in Western Province. And the third one is still in progress, and it's on food insecurity, which will be published anytime when it is finished. My take-home message is, in any career path, you have to start somewhere, and as you tread on, you will learn the necessary skills required to help you become better at it. And giving your best in doing what you do with passion will help you come to realize the importance of what you do. And for me personally, as a researcher, it's like me opening a door to a house, and then the moment when I step in, it's like there are other doors and windows there for you to open. So thank you very much to all the my senior staff members and project coordinators who have helped me to become better at what I'm doing, and also looking forward to do what I can do in the research field. Thank you very much.
I'm just going to quickly close up this session. First of all, let me say that as social researchers, we're not very tech savvy, but I also want to just give a shout out to our amazing tech support for today. They're certainly earning their money's worth with our team, but thank you for their patience as we're wrapping up this particular session. I firstly want to acknowledge the Buttressing Coalition and the organisers of the virtual symposium today, and thank them for their time and for allowing us the space to present some of what we do in social research work in public health. I also want to go back to my point of us being human. I hope the takeaway message for everybody is that without the people that we work with, the communities that support us to do our research and to provide us with the nuance and detail that they do, we are then able to understand our communities better, but also through their own voice. How do we then address some of their concerns and issues in focused and practical and important, realistic ways? Also drawing on what Agnes has talked about, I think one of the prominent things that I've certainly learned at my time at the PNGIMR is about equitable partnerships and what that can look like. They're made possible because they grow over time. It's part of our research practice to grow and use methodologies as well and new technologies, and that comes with the support and the guidance of our partners, but it also comes with our own input into what is needed in our communities. From Herrick's work, I think it's really important to take away a message of our social research can deepen our understandings, not just as a community or a public as a whole. It deepens us and our understanding as researchers as well. And to take a little bit of license over John's apt metaphor, research opens the door to answering questions. behind that door, other doors might be available to open and explore and to find out the answers that can be useful for us. On that note, I'd like to thank you for this time and thank you for your patience with all the tech issues. I'm going to cross back over to Dr. Laman.
Thank you, Nalisa, and thank you to our social science researchers at the Institute. This was our opportunity to give them the spotlight and the opportunity to present some of the work that they have been doing over the last many years. Okay, I would like to briefly introduce our next documentary. It's about the success story of our insectary. You know, at the vector-borne unit, our entomology teams are one of the strongest, and we are proud of them and their achievement. For us to be able to do some of the experiments on vectors, it's not an easy task, and you need to have a insectary and colonies of mosquitoes that we can sustain and maintain over long periods of years to be able to do the experiments they do. But to keep the colony going for 40 years, that's another story. And so as part of this documentary, this 20 minutes documentary, we will hear about the success stories of the insectary at the vector-borne disease unit at the entomology section at PNGIMR. Thank you.
This is a success story of an insectary that was set up in a rural setting at Yagaum that is located 30 minutes outside of Madang town in Papua New Guinea. Through many years of malaria research in PNG, the insectary that was set up by Derek Charlwood in 1981 became the centerpiece of carrying out outstanding malaria research over 40 years in PNG and the global community. The research generated from the insectary involves testing transmission dynamics in known laboratory reared mosquitoes and insecticide-treated test that is rolled out as a nationwide control intervention. This documentary presents the success story of the Papua New Guinea Institute of Medical Research Insectary.
Of Sakel, we've been working on the entomology lab.
Hi, I'm Lisa Reimer, and I joined the entomology unit in 2009 and spent 4 years working with the team.
My name is Michelle Katuseme. I'm a senior scientific officer with the entomology lab at the PNGIMR vector-borne diseases unit in Madang.
Nimblomi Hega Sakel. I start work on the PNGIMR in 2010. I work as a lab technician.
My name is Lincoln Timinau. I'm currently a PhD student studying at the James Cook University and also working as a senior scientific officer at the PNG Institute of Medical Research.
In a long period of time, me no talking Pidgin. So I'm sorry, I have to speak in English. It was around 40 years ago that we attempted in Madang to start a small colony of Anopheles ferroti from Bilbil village. It took a little while to get it going because as with all these situations, the mosquitoes didn't really want to mate. So we introduced tutor species in the form of Culex quinquefasciatus males to get the mosquitoes, the male mosquitoes, swarming and eventually mating.
Along 1983, Patricia Graves, Tom Bucket, Raymond Paru, itisimi na line me. Emi make him na talk, you look him na you behind me. How emi line me long walk him kai long all. First insta, second insta, na third insta lawe, one time fourth insta. How lo tisimol pupa, na how lo putimoli go inside, lo net, na how lo breedimol can, so next round by come up. Time me adult mosquito come up, and me maskisim na larim only stop angry for 3 days. All get a mama mosquito pulling blood now, me rouse him, na me put him go inside long. Me carry net want the mama mosquito, he go put him little sugar pad, na he stop for 3 days. After 3 days, mama mosquito by pining water lay him egg. So me by go kiss him little this, bowl this, na cut him all filter paper, put him lo this, na put him water now, put him go inside lo net. So that mama mosquito by go lay him egg inside lo this. Me browse him there's a filter paper, he got egg, put him inside, na first install by he go and by come up. So me must give him kai long all, blow all first insta, me must give him kai. Na second insta time, me go second insta, and now me by try me walk him narap la kai long all, third na fourth. After lo des la third fourth, kai go all kai na only come up pupa now. Only come up pupa now, and me by rouse him pupa lo tube. Me rouse him all, na me by put him inside lo one black cup water. Na me put him go inside lo net, na inside lo net, by all emerge. Na only fly that wing. Now me by walk him sugar water, put him on top lo net. So all after long 3 days, all female mosquitoes want a male mosquito, all crossmate finish. Me put him, me rouse him sugar pad, na larium all female by ilakisim blood. And this la and by go na enough by this la colony by go round all same tasol. While me walk him this la, he got narapla next load walk lo come. So me must keep up one time this la all get a step by step. Now me by round he come back in. And colony belong mosquito and me must keep him. For how much years me walk him this la, you go na, and me experience finish long this la.
When I joined the unit, the first thing that we wanted to do was to establish local colonies of Anopheles punctulatus and Anopheles ferrauti. And colony establishment can be really, really challenging for some species. So mosquitoes need wide open spaces and they need, natural cues from the environment in order to mate and seek out a host and blood feed and lay eggs. And so we ran into quite a few challenges at each of those stages. So we had to build really large cages to give them space to swarm and mate. But then the cages were so large that we also needed really a critical mass of mosquitoes in those cages. So everybody got involved with collecting larvae, identifying mosquitoes and putting the right species into the cages. And oftentimes we would have to supplement with artificial mating. So individually, hand mating each female in order to get that critical mass of mosquitoes in the cage.
Why did we create a new backcross colony of Anopheles ferrauti? So in 2012, we realized that our Anopheles ferrauti colony mosquitoes were maintained for a really long time and could have probably lost the ability to successfully carry malaria infection, or they were refractory to malaria infection. So led by Dr. Neisseria, Heiga Sakel, Walpuma, and myself did a series of experiments to create a new backcross colony of Anopheles ferrauti. So we did a couple of experiments to do this, to backcross the Anopheles ferrauti colony that we have here at the Agaum, with wild Anopheles variety from Dogia and Maraga area in Medang, the south coast of Medang. So these experiments, we did a series. We first got wild larvae of Anopheles variety along Dogia and Maraga, and we tried to breed them with colony larvae here in Yagaum in cages. However, we found that the breeding rate for them to naturally mate in the cages was really low, so it was unsuccessful. And this we determined by doing spermatica dissections under the microscope to see whether or not there was mosquito sperm present in the spermatica or not that indicated successful mating in a female mosquito. So we found out that it was unsuccessful to breed them directly in cages. So we decided to do another experiment where we collected wild larvae from the Maraga and Dogia area. Again, we brought them back, reared them until they were at the pupa stage, and then using the microscope, we separated the males from the female. So female pupa and male pupa was separated into different cups, and then we did the same for the our colony Anopheles variety mosquitoes. So then we had two cages, where one cage had wild female pupa and colony male pupa, and vice versa. The other cage had colony females and wild males. So then we let them emerge, in the cage, and they became adults, and then waited to see if they successfully and naturally mated within the cage conditions. Initially, it was low mating, natural mating, so we supplemented the reproductive rate by doing artificial mating, where we got other adult male and females from each respective cages and did force them to mate to increase our rate of the number of females that were mated. So this was done from January 2012 to March 2012. So by early March that year, we successfully had our first generation of eggs from these two cages. From that experiment, initially when we did the experiment, we were hesitant that it would not be successful. But once they quickly adapted to our insectary conditions and protocols, we had no doubt that we had successfully created the new Becker's Anopheles variety 1 mosquito colony here at PNGIMR.
Now that we've got all the adults in these huge cages, they need humans to feed on, and they only feed at night. And so we had to bring these cages home on the bus from Yagaum and blood feed them every single night, sticking 2 legs and one in each cage, sitting in the dark for hours in the evening, trying to get them to feed, really nurturing them through every single step of the way. Everybody in the team was really invested in these colonies, and eventually we were able to get them adapted to artificial feeders, and we were also able to set up the insectary so that we had reverse day-night cycles, so that we didn't have to work with them through the night, round the clock. The insectary was simple, but we were able to achieve appropriate containment and also a stable environment, stable climate for our experiments, using local materials and a bit of creativity. And I really felt like there wasn't a limit on the work that could be done in that insectary. Before too long, the team were conducting experimental infections with filarial worms and with malaria. And this is work that requires really strict protocol adherence and controlled experimental conditions. But some excellent work came out of the unit and continues to. And I think that personally, the infection work that I was involved in really has been the highlight of my own research career.
My PhD project was basically looking at the transmission of malaria parasites from humans to mosquitoes. And in order to do that, I needed a large number of Anopheles variety mosquitoes. So in 2015, we improved the called a rearing protocol so that we could maximize the numbers, increase the number of mosquitoes that we produced, and also worked on trying to improve how the mosquitoes were being fed and the little conditions surrounding the feeding of these mosquitoes. And we have successfully improved our rearing capacity, and the largest number of pupa that we collected in a day was 9,000, which is a record for us. A really nice setup here where we can successfully infect our mosquitoes with Plasmodium vivax parasites, and that puts us in a very unique position to currently collaborate with other scientists around the world to test potential transmission blocking vaccines or antimalarials that can inhibit the growth of parasites within the mosquito.
And thinking back on my memories of the insectary, I'd say there's three things that stand out. One is the expertise of the technical staff, especially Wallaf, who knew exactly what the mosquitoes needed at any given time, and our collectors who knew where to find each species of mosquito, both larval stages and adults, and their skills with identification.
Namel time iga sampla kain or University Sumatin long overseas isekam na also like go round only looking experiment blong along colony finish na mi plabay go out miximol go out lo how mi bay go collectimol healthy lavia and mi play mi sa behind him road one cup na mi sa kisimol o igolo one site blow IMR ento isa go about by play go ties kisimol they come na by only make him experiment blong only.
Second would be the enthusiasm of the early career researchers who joined the group. I remember some of them would come sneak into the lab late at night just to watch the mosquitoes, see what they're up to, and watch their behaviors. And I think that this enthusiasm, as well as some diligence to really optimize new protocols, helped move the expertise within the group forward.
Insectary one interesting building where mi ama mas lo staff na lukauti mosquito na maintaining mosquito colony when interesting lo you lukauti mall challenges em sa come up or lawisa die sampla lawisa die mi plaza sort lo mosquito because mi plan no got enough lawi lo broimo lo collecting pupa na si mosquito tasol plus by anyways lo how ba mi pla make him lavi go plantin na kisim back mosquito la lookout team Anopheles one them mixed colony so mi pla blood feed lo mosquito direct feed lo mosquito lo cages lo sim beds egg beds na maintain him desplatopla colony inside the insectary.
As all of you probably know, insectaries provide a great deal of useful information because the insects in them are known and can be known, their genetics can be known, and their resistance status to insecticides can be known, so that they are, for example, useful for bioassays or testing new insecticides. They're also very useful for doing xenodiagnosis, providing information on mosquitoes that feed on people who are asymptomatic from malaria, say.
As part of my PhD, I was interested in understanding the contribution of asymptomatic infections to our mosquitoes, and hence I have brought our colony mosquitoes to the field where we allowed 30 of our mosquitoes in which were prepared in a cup to directly feed on healthy individuals within a village just to see if they would transmit malaria parasites through our mosquitoes. And so far we have established that asymptomatic transmission is ongoing in our villages, and more needs to be done to fully understand how much is being transmitted in order for us to really look towards eliminating malaria within our country.
It was really just a small enterprise, but as they say, from small acorns, large oak trees grow. And so I was very pleased to hear how successful the insectary at the PNGIMR has been over the last many years. So, very well done, and my congratulations. Many more years of work.
It's the excellent science that was produced collaboratively by the team. I think that, research that's conducted using local species has been transformative in informing, vector control policies in Papua New Guinea. Papua New Guinea mosquitoes have significant diversity, very different behaviors and susceptibility than other, global strains of mosquitoes. And, because that's different, any approach to malaria control, filariasis control, arbovirus control really requires research on those local mosquitoes because the solution for PNG is not going to be the same elsewhere. And, I've definitely seen PNGIMR entomology unit really leading the way and producing really exciting research from the insectary. And with these new facilities coming, I just can't wait to see what comes next.
Despite the challenges posed by the ongoing effects of COVID-19, successful progress has been made on the NATNAT project here in PNG. NATNAT aims to build a framework in PNG for the rapid assessment and adoption of novel vector control tools in PNG. This insectary, also known as Bella NATNAT Center, is one of the first objectives of NATNAT to strengthen laboratory, semi-field, field capacity to test new vector control tools in PNG. As you can see, right now, construction work is still ongoing. Thus, we are aiming to complete this project by the end of 2022. Nothing here can be done without highly effective partnerships from our Product Development Partnership Team, the IVCC Indo-Pacific Initiative, led by Fred Yeomans, the Rotarians Against Malaria team led by Mr. Tim Freeman, the National Department of Health team led by Dr. Melinda Susaku, the National Malaria Control Program team led by Mr. Leo Makita, Barne Institute team led by Dr. Leanne Robinson, James Cook University team led by Dr. Stefan Kal, Papua New Guinea Institute of Medical Research team led by Dr. Moses Laman, National Department of Works in Meday, and Ella Builders and Contractors in Meday. As you can see right now, construction work is ongoing. Thus, we are aiming to complete this project by the end of 2022.
Thank you very much, everyone, and thank you for the previous sessions for all the great work that they've shown to us. I'm now going to the pneumonia session, and in this session, we'll have the fortune of having Professor Ian Riley, who will talk to us about the early work on ARI here in Papua New Guinea in the 70s and 80s. And he's the great shoulder upon which we stand on to conduct our pneumonia research. Also in the session, we'll have Kaldor, who will talk a little bit about the impact of pneumococcal vaccines on pneumococcal carriage and antibiotic susceptibility. And after that, we'll have Professor Chris Bly, who will be talking about pneumonia research in PNG. His topic is old foes and new threats. And some innovation in that Dr. Kate Mellor will be talking to us about genomic surveillance of strep pneumo using isolates from Papua New Guinea. And after that, we'll have Professor Fiona Stanley from Medoc Children's Hospital, Medoc Children's Research Institute, who will say a little bit about where next and how to get there. But before that, I'll start with my own presentation. And so provide you with a little bit of overview of the pneumonia research program that has happened over the last few years. Pneumonia research, as you know, I guess for the first time in the world, the pneumonia research program was one of those that began the multidisciplinary approach to research, looking at the epidemiology, bacteriology, virology, immunology, clinical studies, social sciences, and genetics. And the aims of these were to look at the burden of disease, etiology, risk factors, evaluate interventions, and then policy recommendations. We know that pneumonia has about 800,000 kids die each year globally in PNG. It is also the most common reason for children to be admitted to the hospital. And the Pediatric Society annual report showed in 2021 that 4% of children who are admitted with pneumonia to the hospital die, and among those admitted with severe pneumonia, 9% of those would die. And the latest demographic and health survey found that 63% of children with pneumonia, or of children who had pneumonia-like symptoms, sought treatment. So most pneumonia deaths are preventable, but there are many challenges. This is a picture of carriage of pneumonia, and as you can see, the first curve that goes up is carriage of strep pneumo in Papua New Guinean children. And so PNG children acquire pneumococcus early, and by 4 months of age, almost 100% of kids already have strep pneumo in their nostril. And carriage is a prerequisite for disease, either in the middle ear, in the lungs, or in the brain. And so the use of vaccines, and when we started vaccination, or now that we're vaccinating, is limited by the number of serotypes of pneumococci that children might be having. This may mean that the current vaccines are not suitable or may not be as effective as they should be. This slide I stole from Trevor Duke, who also does a lot of very good research on pneumonia in Papua New Guinea and from a clinical perspective. And it shows the oxygen concentrator for treating severe pneumonia here at the Goroka Hospital. One of the researchers that worked on this is Dr. Francis Wandi, who's currently the CEO of Kundiawa Hospital. And a lot of this work is already in place and helping to treat children with severe pneumonia. The IMR work continues to benefit and has benefited so many, and we've got research partners from the Telethon Kids, Ian, previously from the University of Queensland, West Farmers, University of Western Australia, the Medoc Children. There's a lot of partners that we work with on pneumonia. A lot of our funding comes from NHMRC, ExxonMobil, DFAT, Government of Papua New Guinea, WHO, and NIH. And I'm sure I have forgotten quite a few other sources of funding. And also, the benefits of this research, the partnership is also created between the study participants and the communities that we work in. And we have established that in many of us, in the places that we work in. So what are the influence of pneumonia research on policy? Yes, it has provided baseline epidemiological data, the antibiotic schedule that we currently use, the introduction of and schedules of measles, PCV and HIV vaccines. And it informed the clinical science to including the standard treatment manual, where many of our pediatricians on the show will know about the Blue Book. That arises from the work that's done at the Institute. And some of our contribution to research and control of ARI internationally includes guiding methods for demographic surveillance in resource-poor setting, development of WHO treatment protocols, establishment of lab methods for carriage studies, and development of concepts of acquisition and invasiveness of pneumococci. GAP, or now it's called the Integrated Global Action Plan for Pneumonia and Diarrhea. Some of the work we do contributes to that, and has produced some of the current studies that we're working on are genomic surveillance, and later on Dr. Kate Mello will talk a little bit about that. Some of the causes of viral pneumonia. Obviously, the IMR celebrated 40 years in 2010. The 50 years of pneumonia research was in 2020, at the height of which we had COVID vaccine. And so viral pneumonia are important in the etiology of pneumonia. We're currently also working on otitis media, its etiology and prevalence, which you have heard earlier by Celestine. And some of the work that we're also looking at is combining probiotics with vaccines to see if this improves vaccination efficacy. As well as that, we're working with the University of St. Louis Washington in St. Louis to look at host determinants of disease to see whether there are genes that contribute to susceptibility of children to pneumonia. What are the future? Well, we need a national surveillance. So there's already, with COVID-19, there's already talk about creating a surveillance for Papua New Guinea to look not only at viral infections, but other surveillance for other viruses, bacteria, and everything else in between. Increase the uptake of vaccines. Obviously, it's good to have vaccines, but putting them into arms is probably one of the biggest problems that we have, as well as evaluating RSV vaccines, other vaccines, and approach to different vaccine schedules. One of the work we're doing currently is to look at whether we can look at the nature of genomics and to see what genetic network can be initiated to provide protection to children at birth. Now, we don't know the etiology of pneumonias in children. What are they like? And also preventive strategies. Vaccines are not the only strategy that can be used to reduce pneumonia. There are things like housing quality, air pollution, early treatment seeking behaviors, and probiotics. Many of our kids that go to hospital are already very sick before they get there, so we need to change the mindset of parents to bring the kids earlier. And use of new and old methods such as genomic sequencing and demographic surveillance. And with that, obviously, we need funding for many of the future research. Adding Deborah Lehman's award, research award, is something that young scientists can apply for. It will be available in August of 2023, where you can apply for and begin your research into pneumonia or acute respiratory tract infections. There's been capacity building for a lot of staff, and here I've listed some of them. Obviously, myself and Peter Siba heading the institute, have and are heading the institute. And our training comes from research work on pneumonia or ALRI. We've got Dr. Celestine, who has completed a PhD and now working on otitis media, and a whole lot of other staff who have benefited from the work that the institute does on pneumonia. Obviously, like I said earlier, vaccines are one of the factors that we need to look at, but there are other areas, and this comes from Michael Alper's 2010 domain for discussion, and it includes a lot of areas, including good nutrition, environment, an integrated approach to making sure that we reduce the level of pneumonia in the community. These are some of the publications that we currently have. You can go online to visit those, to have a read about all the work that has been done and will continue to be done into the future. And I'd like to thank all of this, and especially Ian, Bob, and Deborah for being the foundation from which the pneumonia research has risen from and continues to work towards and work forward on. And at the bottom is only a snapshot of the number of staff that have worked. There have been a lot. So like I said, in 2020, we should have celebrated 50 years of pneumonia research. Unfortunately, that didn't happen because we had other a pandemic to deal with, but there's been a lot of staff that have come and gone through the Institute working on ALRI. So, and with that, thank you very much. Before I go to Ian, I'd just like to say that I forgot to mention that Chef Peter Butter also passed away, so we'd like to also remember him as one of us, one of those who has really worked hard to support the Institute. So with that, thank you very much.
Okay, thank you. I'm going to talk about the first 20 years of the ARI research or the pneumonia research, and like to show how they laid the groundwork for later research on the pneumonias. There were four major research streams: clinical research in adults, which was where we started, clinical research in children, population-based research led to an understanding of the epidemiology of ARI, and the field trials of the pneumococcal polysaccharide vaccines. There was also work started by Mike Grattan and others on the upper respiratory ecology of bacteria and mucosal immunity. In 1967, it was recognised that pneumonia was the leading cause of death in hospitals and in small population in studies in Papua New Guinea, but there'd been no research. The assumption to that point was that antibiotics would take care of pneumonia, and it was obvious that they were not. There were high admission rates of young men with lobar pneumonia to Angao and Moresby General, and this was shown to be pneumococcal pneumonia with gram-positive bacteremic shock. A lot of these young men died. Procaine penicillin was as effective as crystalline penicillin in the treatment of lobar pneumonia. But the appearance or the emergence of penicillin resistance meant that procaine penicillin was no longer a universal remedy. We started population because of the 68-69 Hong Kong influenza pandemic. It was devastating in the Southern Highlands. Pneumococcal pneumonia was considered to be the leading cause of death, and it was a well-known, well-recognised complication of influenza. This was never confirmed in the laboratory, however. In 1971, we commenced population-based research in Tari. And this confirmed pneumonia as the leading cause of death in adults. We showed, with a major field trial, that pneumococcal polysaccharide vaccine prevented death from pneumonia in adults. Also, in a sense more interesting, maternal immunisation prevented infant deaths from pneumonia. And one of the reasons for this was that we couldn't work out whether a woman was pregnant in the first 3 months of life because she didn't want to tell anybody. We came to recognise the importance of child pneumonias. And an important finding was that highest case fatality occurred in the first 24 hours after the onset of fast breathing in children not accessing antibiotics. In other words, a mother or a family had 24 hours to get the baby to an antibiotic within 24 hours of the emergence of fast breathing. Otherwise, that child was at severe risk of death. We also showed that pneumococcal polysaccharide vaccine prevented death from pneumonia in children, including those less than 2 years of age. And this was a very controversial finding at the time and not accepted by many people. People standardised the clinical diagnosis of infant and child pneumonia, and this provided the basis for diagnosis in population studies and for rural health services where there were no X-rays. It contributed to the manual for standard treatment for common illnesses of children in Papua New Guinea and provided the basis for subsequent classifications of child pneumonia. The manual, in my opinion, was absolutely groundbreaking. It was terribly important. Both pneumococcus and Haemophilus influenzae were causative agents. In one study in the Goroka Hospital, however, 25% of children were bacteremic. This was unheard of in the international literature. And case fatality in these children was 5 times that in non-bacteremic children. As you've heard in other presentations today, severe bacterial pneumonia in infancy was a consequence of the acquisition and nasopharyngeal carriage of high densities of H. influenzae and pneumococcus in the first 3 months of life. Elsewhere in the world, children encountered these pathogens when they went into the larger world, when they went to preschool or something like that. But these children, these infants, were so densely colonised, they very often back-infected their mother. So we felt that pneumococcal polysaccharide vaccine efficacy in preventing death for pneumonia in children under 2 years could be explained by the fact that the vaccine was immunogenic against highly invasive adult serotypes of pneumococcus, which were common in child pneumonia. In other words, you could not translate results from 20th century or 1960s America to Papua New Guinea. Have there been changes in the pattern of pneumonia over the years? Certainly, the lobar pneumonia and high death rate in young men appears to be a thing of the past. I don't understand about children. I asked the question whether there'd been a change in the epidemiology of carriage organisms. Internationally, WHO recognised that pneumonia was a leading cause of death in many countries, but nowhere was it acknowledged that pneumonia was a priority for public health. In other words, antibiotics were there to take care of pneumonia. The WHO Global Programme for Control of ARI was based on PNG research. And at that time, pneumonia was the leading cause of child death globally with 2 million deaths. The focus of the WHO Global Programme was on the diagnosis of treatment of disease and not on vaccines. There was controversy about the relative importance of bacteria and viruses based on the North American experience. And PNG experience of the critical importance of bacteria was vital to understanding of the disease. The PNG and South African trials of pneumococcal polysaccharide vaccine in adults led to its licensing in the USA. These 3 countries were aware that antibiotics was not enough. And Tasol and Licklick-Tok-Tok-Balami. Thank you, True.
Hello, everyone. My name is Tilda Orami, and I work with the PNG Institute of Medical Research in Goroka. I will be presenting on behalf of my team on the impact of PCV10 and 13 on pneumococcal carriage and antimicrobial susceptibility. In early pneumococcal studies done in Papua New Guinea, children were colonized with dense pneumococci and pneumococcal diseases. And by the age of 3 months, all infants carry streptococcus and persist throughout childhood. The 7-valent pneumococcal vaccine have shown limited impact on the PCV serotype-specific carriage among Papua New Guinean children. And in this study, we saw high prevalence and density of pneumococci carriage at 1 to 9 months. Both PCV were found to be safe and immunogenic among these children. Our aim was to investigate the impact of PCV10-13 on pneumococcal carriage and to determine the antimicrobial susceptibility of the pneumococcal carriage isolates, and also to assist the Department of Health in choosing the appropriate pneumococcal conjugate vaccine for the national immunization program. This study was conducted in Neisseria Valley in 2011 to 2014. And nasal swabs were collected from 262 infants and were cultured using the standard bacteriological procedures, and antimicrobial susceptibility were done on the confirmed Streptococcus pneumoniae. This graph shows the pneumococci serotype distribution at 23 months. A total of 71 different serotypes were seen at 1 to 23 months and 48 at 23 months. The prevalence of PCV serotypes was 23%, and the most common PCV serotypes was 23F, 6A, and 19A. And non-PCV serotypes were 6C, 35B, 15B, and 16F. And the prevalence of non-serotypable pneumococci was 10%. This result shows the prevalence of streptococcal carriage all throughout the study and for the 2 vaccine groups. The blue bar represents all the pneumococci isolated, and the red indicates the non-PCV serotypes. Green are the PCV10-13 serotypes, and the purple are the 3 extra serotypes found in PCV13 vaccine. A total of 974 pneumococci were isolated from 883 nasal swab, and more than 80% of the pneumococcal coverage was seen at age 4 months and onwards, and the highest was seen at 23 months at 91%. The non-PCV serotypes coverage was more than 50% at post-PCV, and the prevalence of PCV10-13 set serotypes were lower in PCV13, and in general, the prevalence of PCV13 only serotypes were lower in serotype 13 recipients. These are the results for the non-susceptible to penicillin among the 2 PCV groups at 1 to 23 months. We found that 46% of the pneumococci were non-susceptible, and approximately 1% was fully resistant to penicillin. The non-serotypable pneumococci were most frequently non-susceptible, followed by serotypes 14, 19F, 10A, 19A, 15B, and 35B. More than 70% of serotypes 14, 19F, 19A, 15B, and 10A were non-susceptible to penicillin. This graph shows the results of the trimethoprim sulfamethoxazole. We saw more than 40% of pneumococci non-susceptible to trimethoprim sulfamethoxazole, with 17% being fully resistant. Non-serotypable pneumococci were most frequently non-susceptible to, followed by serotypes 23F, 19A, 10A, 14, 19F, and 35B. And more than 70% of serotypes 14, 19A, 10A, 15B, and 9N were non-susceptible to trimethoprim. Children in the islands of Papua New Guinea still experience persistent pneumococcal colonization by broad range of streptococcus even after primary schedule of PCV. Previously shown PCV13 has no impact on carriage density, including PCV serotypes. And approximately half of the carried pneumococci were non-susceptible to penicillin or trimethoprim sulfamethoxazole, with high rates of non-susceptibility in non-serotypable isolates and several PCV serotypes. And finally, to acknowledge the following study participants and their family, PCV study team, the funding agencies, and the collaborators. Thank you for listening.
Thank you very much for the opportunity to present, Willie, for the invitation, and I've enjoyed the presentation so far. So I've been specifically asked to look at some of the more recent work in Papua New Guinea on pneumonia research, and I'm importantly keen to acknowledge there's a number of collaborators that have been involved with this work, and funders. The funders have included Pfizer as well as the Gates network have funded some of these studies. But I'm going to touch on a couple of elements here. I'm going to sort of talk to what I believe has changed over the last number of years, to talk about some of the pneumonia program in more recent years, focusing on etiology, the clinical predictors of severe outcomes, and vaccine uptake and effectiveness, and looking at next steps, at least in my mind. I think there has been a number of challenges, a number of changes clearly since the introduction of conjugate vaccines. Pneumonia is different in a number of countries, including in PNG, and that has been a real benefit to children globally. I think our diagnostic strategies have changed since some of the earlier studies that have done with more ubiquitous use of PCR. And also, I think in the COVID era, we need to highlight that some of the pathogens have changed. We've discovered new pathogens that are likely to shape what our picture of lower respiratory tract infection is in Papua New Guinea. I think there's some of the challenges, certainly as highlighted, the challenges of early bacterial colonization and frequent transmission of pathogens within households and communities remain, and this will continue to be a significant challenge in the Papua New Guinea environment. I talk about distrust and hesitancy. I think we acknowledge there is some distrust and hesitancy about vaccines in a number of countries, and this is clearly a challenge going forward. And access to healthcare remains a challenge for some Papua New Guineans, and that will continue to shape what things look like. I'm going to present two data sources. The first is a study that was funded by Pfizer, which was a case control study looking at etiology of pneumonia and meningitis. And the second is a new captive study. I see that Fiona Russell is online. She is the PI of this study. It was a study funded by Gates in 3 centres, Papua New Guinea, Laos and Mongolia, and really looked at what sort of coverage we need with the pneumococcal vaccines to try and get some of the indirect effects that are so powerful with these vaccines. And I'll present some results from that. The burden of pneumonia, this is some early data done by Kate Britton, who's a PhD student, shows that pneumonia remains, even in the recent era. This is hospitalisations from gonorrhoeae, a major driver of hospital admissions, but those working in this area would see this every day. Etiology is likely to have changed, but many of the challenges in determining etiology remain. Of the nearly 1,000 children we recruited into the case control study, confirmed bacteremia occurred in only 4%, of which half were pneumococci. But what was a real driver of disease in those who didn't have bacteremic pneumonia remains difficult to determination, and we did struggle with the contamination rate of blood cultures in this study over this period of time. I think it's important to highlight that there's increasing evidence about the role of respiratory viruses in pneumonia etiology. This is a systematic review that we've recently published demonstrating that both low and middle income, as well as high income countries, respiratory viruses are detected in more than 50% of children with pneumonia. And this is likely to be the case in Papua New Guinea, as demonstrated by some of the work from the case control study. And in a real shout out to Sarah Javati and Alison Lang, who drove this work in those children between 2013 or 2016 matched cases and controls. We found viruses such as RSV, such as rhinovirus, and such as paraflu in a number of those children, nearly 20% with RSV, nearly 14% with nearly 20% with para-influenza virus, and clearly differences between cases and controls, particularly for these more pathogenic viruses such as RSV and paraflu. Of interest, not much flu was detected in this study. I'm going to jump to pneumonia management, and really some of the existing treatment manuals have done very well as far as trying to streamline management of pneumonia in Papua New Guinea, and a real shout out to the original authors who drove this process. But things have changed. One, much more ubiquitous access to pulse oximetry, which is a wonderful thing. Greater access to oxygen in healthcare facilities. Two, we have different diagnostic tests available to us. So my question that we need to raise is, some of the signs that we've looked for previously still relevant? And this is work that Kate Britton has led, looking at predictors of severe pneumonia, such as hypoxic pneumonia and death. And importantly, really highlighting that some of the danger signs that are familiar in Papua New Guinea and in other countries using the existing WHO documents are still relevant. So drowsiness, tachycardia, nasal flaring, reduced breath sounds, central cyanosis and skin turgor being relevant risk factors. And this is early work that we're in the process of finalising for publication at this stage. In my last slide, I think it's important to talk about uptake and effectiveness of pneumococcal vaccines, as well as it is for Haemophilus vaccines. We have seen, particularly in the studies that we've been doing, an increased uptake, which is really pleasing to see, post-introduction in 2014 to 15 to with nearly 70% of children enrolled in the clinical studies in 2019 having access to a PCV vaccine. And it allowed us to really look at actually what is really happening and are they working. And I think the take-home message is these vaccines are working. Pneumococcal vaccines are working in preventing severe outcomes such as hypoxic pneumonia or PNG-defined severe pneumonia and hospitalised pneumonia. So really having effects far greater than some of those original etiology studies would suggest, suggesting the burden of pneumococcal disease driving pneumonia remains highly a really important cause of pneumonia in Papua New Guinea and demonstrating the power of vaccines in reducing disease in children. And with that, I suppose I'm going to highlight a couple of steps. The etiology challenges remain, but actually we need to continue to look to how our vaccines are working and look to the impact of those. And we actually have to go to the next step, is making sure timely access to vaccines and we monitor the impact of those vaccines, because as demonstrated in other countries, the etiology of pneumonia and lower respiratory tract infection is going to continue to evolve with vaccines and alongside vaccines. So we need to keep abreast of that, particularly as newer vaccines come on board. And so importantly, a shout out to all the collaborators who've done this work and our funders. I will stop sharing my slides. Thank you very much.
Hello, my name is Kate Meller. I'm a scientist working in the Global Pneumococcal Sequencing Project at the Wellcome Sanger Institute in the UK. The project focuses on genomic surveillance of Streptococcus pneumoniae. Today, I'm going to give you a brief overview of the project and also some recently published work that was done in collaboration between PNGIMR and other GPS project colleagues. The GPS project aims to give a global view of pneumococcal evolution, both pre and post the introduction of vaccines, so that vaccine escape can be detected and also we can inform the design of new vaccines. So far, there have been over 26,000 isolates from over 50 countries worldwide that have been sequenced. We're now in phase 2 of the project, and our focus is now on countries with a very high burden of disease and those countries that were not well represented in the first phase of the project. So that includes India, Nigeria, DRC Congo, and Pakistan. The GPS project also aims to support local data generation. So that includes both sequencing and analysis with support from the central team. So we work directly on individual projects and also we help to provide some bioinformatic training. At the end of this presentation, I'll provide some contact details in case you're interested in accessing training resources. So traditionally, we have used serotyping to characterise Streptococcus pneumoniae. This is based on the capsule, which represents a small part of the genome and can be determined either phenotypically using antisera, or now we can do it directly from whole genome sequence data. The region of the genome encoding to the capsule ranges from about 10 to 30,000 base pairs, which is a small fraction of the around 2 million base pairs which comprise the entire Streptococcus pneumoniae genome. Using the whole genome data can therefore give us a much greater resolution, and that enables us to more robustly evaluate the epidemiology of Streptococcus pneumoniae. We can cluster these isolates into lineages based on this whole genome information. Using this information, we call these, where we have these isolates into lineages, we can look at tracking these over time and across regions. So we can see if the same serotype emerging in multiple different countries is due to an international spread of a particular strain, or whether we are having independent emergence in multiple different locations, for example. We can also use this information to guide vaccine design and even to forecast the impact of future vaccine use. It was a great pleasure to work with Deborah Lehman, Rebecca Ford, and other colleagues to perform a genomic analysis of isolates from Papua New Guinea. In the study, we used isolates from 1989 to 2014. So that was prior to the introduction of PCV13 and provides a baseline for future comparison. Around 75% of isolates were from children with meningitis, with or without pneumonia, and the remainder were from children with pneumonia. As had been established already from other studies, around half the isolates were non-PCV13 serotypes, and over a third of isolates were resistant to one or more antimicrobial. We put isolates from Papua New Guinea into the global context and can see that the population was distinct from other countries. So we had 17 out of the 48 lineages only ever being observed in Papua New Guinea. And in the cases where we saw a lineage that was also observed in other countries, the isolates from Papua New Guinea typically clustered together, distinctly separate from those isolates from other countries. An exception to this was the most common lineage, which expressed serotype 2, and there's a phylogeny shown on the screen here. This figure shows the isolates from the lineage in the global context, and you can see that the isolates from Papua New Guinea, which are in the pale green colour, form two clusters, the larger one being highly distinct from other locations, so that's here, and you can see the other, which was more closely related to isolates from other countries, which could indicate long-range transmission. Serotype 2 is not included in PCV13, but it is included in 2 vaccines that are currently in development. We also observed multiple lineages with isolates expressing both PCV13 and non-PCV13 serotypes, which highlights the potential for rapid serotype replacement and vaccine evasion following vaccine use, and may benefit from further monitoring using whole genome sequencing. I'd just like to highlight that the GPS project is teamed to stay connected with project partners, and we have a bi-monthly seminar that you would be very welcome to join. It covers diverse topics relating to both strep pneumo and group B strep, with collaborators contributing each time, and you also have the opportunity to meet with others and share your experiences in small breakout groups. Also, if you'd like any support with bioinformatics training, please do get in touch. We have a couple of online courses and are happy to provide ongoing support to you. You can visit our website to find out more. I'm now on maternity leave, so if you would like to join the mailing list for the seminar or training opportunities, or if you've got any other queries, then please do contact Jolyn. Lastly, I'd like to thank you for listening, and to all GPS.
Great, good afternoon, everybody. So I'm Professor Fiona Russell, and I would like to thank Professor Pomat and the organisers for asking me to participate in this panel session on childhood pneumonia. So I'm a paediatrician based at the University of Melbourne. I'm an infectious disease epidemiologist and vaccinologist, and I'm also group leader for the Asia Pacific Health Research at the Murdoch Children's Research Institute. So I was asked to just reflect on really some of the research needs sort of going forward, but also putting them in a sort of a global context, I guess. So I've been working in the Asia Pacific region for the past couple of decades on pneumonia particularly, but also supporting countries with new vaccine introduction and the research and data needs to sort of support those decisions. So one of the really critical things that is needed is surveillance. So, you know, when countries want to introduce a vaccine or, you know, prevent a disease, it's absolutely important to know how big a problem it is. And so through surveillance, that's a way of identifying the epidemiology. And so now, you know, moving forward, it's really critical to, you know, with COVID and all the other respiratory and viral pathogens and pneumococcal, the bacterial pathogens, is to be able to sort of have an integrated approach to be able to monitor those infections and diseases. Now, in Papua New Guinea, as many of you would know, the pneumococcal carriage and pneumococcal diversity of serotypes is huge and probably one of the largest in the world. And when you introduce a vaccine, such as the pneumococcal conjugate vaccine, you get rid of the vaccine types, but then there's non-vaccine types that then pop up and replace those serotypes. And so the extent of that in many countries, particularly low and middle income countries, is not known. And as far as I'm aware, there isn't that surveillance to be able to understand the degree of that occurring in Papua New Guinea and other high burden sort of countries. So it's very challenging to do pneumococcal disease surveillance because invasive pneumococcal disease is usually there's few cases, you need CSFs and blood cultures and all the laboratory and serotyping things required. And so some of the work that we've been doing is looking at the role of carriage and how good is carriage then to be able to predict what might happen, or predict as to whether that is reasonably reflective of what happens in invasive disease. And so we've been doing a review with WHO, and some of the data from PNG is contributing to that to sort of understand the role of carriage, because that's potentially a easier thing to do in terms of surveillance. The other thing that Chris touched on also is, really the need for better diagnostics to understand the etiology of pneumonia. And we have really poor data on understanding what is the cause of pneumonia, particularly in malnourished children, and also how to manage children who have had measles and pneumonia, and how do they actually get managed after they go to hospital? Because after you've had measles, there's immune suppression, and so how long does that last? And do children need an additional dose of pneumococcal vaccine? Do they need to go on long-term antibiotics? These are the things that aren't known. And then, of course, having behavioural and systems research to understand, to improve, the coverage of these different interventions and access to care, and also the quality of care and understanding the demand and supply issues. The other thing that's been done recently, so we supported WHO do a review of pneumonia in children, and one of the things that was looked at was looking at a risk-based approach. So children who have had no doses of any vaccine or malnourished are those at a high risk to have poorer outcomes, as you would expect. And so being able to identify those children at the community level, at the primary healthcare level, at the hospital level, and then for follow-up from hospital too, because children who get discharged with hospital are still more high risk of dying, really important to have a look at those risk-based approaches to care. In addition, children are at risk, high risk of poorer outcomes or pneumonia too, if they've been exposed to indoor air pollution. So looking at healthy, looking at cooking smoke and what fuels, and replacing those fuels with cleaner fuel for cooking in the household as well. And then we come to vaccines, of course, which is such a critical part of preventing pneumonia as well as other infections, and one of the most cost-effective things to do. And as Chris has sort of said, prior to COVID, the coverage looked really quite promising, certainly in the gonorrhoeae area and how it went up. But the latest WHO data, and I don't know how good that is, shows that really the coverage from measles is now about 40%. And presumably with all the COVID disruptions and various things, I don't know how reliable that coverage is, but that's sort of very dangerously low. And so there's a really urgent need to be able to to do the social and behavioural and systems research to be able to understand what are these barriers and to be able to improve the uptake of these vaccines, and that's and looking at innovative solutions around that. The other thing is regarding wider valency vaccines. As I mentioned earlier, there's a very wide serotype diversity in Papua New Guinea, and the current vaccine only covers 13 of those serotypes. But what we find is with the serotype replacement, it's pretty much using these wider valency vaccines is pretty much a whack-a-mole type approach, because there's no predictability about what serotypes sort of pop up. And so we really need better vaccines to be able to cover all the serotypes, really, like a protein-based pan pneumococcal vaccine. And critically, the role of RSV in pneumococcal control was highlighted recently with an excellent study from Israel, and Chris touched on this about the role of RSV, but understanding the RSV epidemiology and having a vaccine to prevent, I think, would be really critical, not only for RSV pneumonia, but also for pneumococcal disease control. Because what was found in Israel in children, that when, with lockdowns and all the pandemic measures, that the viruses all went away, and particularly RSV went away. But once and pneumonia admissions all went down. Carriage stayed the same, density stayed the same, but when the viruses came back again, it's, the pneumonia hospitalisation rates all went back up again. And they really highlighted the critical role of RSV in pneumococcal and pneumonia control. And then just lastly, one of the most important things is human resources and the early career researchers. And it's wonderful. I haven't been able to join all the sessions, but I know part of the program is really highlighting all the wonderful research that the early career researchers are doing. And so we have a Centre for Research Excellence, which is on pneumococcal conjugate vaccine disease control in the region. We're having a forum later in the year that we're very fortunate Professor Pomat has agreed to talk at. But we also have a couple of early career researchers from PNGIMR who's part of our early career researchers to be able to try and build up research and networking opportunities and training. So that's all from me. Thank you very much for the opportunity to chat. And I will sign off from there. Thank you.
Thank you very much, everyone. And I'm sure you all enjoyed this session on pneumonia and the work that has been done and is going to be done. And I'm really grateful to Professor Ian Riley, Tilda, Chris Bly, Kate Mello, and Fiona Russell, for coming on and making this session such a success. And I'm sure that we will continue to work on this and make sure that the pneumonia doesn't become neglected, but continues to be one of the primary diseases that in Papua New Guinea, for us in Papua New Guinea, to continue to look at and make sure that it's up there as well. So thank you very much, everybody, for that. And we'll now go into the next session.
So hi, everybody. I just wanted to, before we go into the next, introduce the next spotlight session, I just wanted to acknowledge everyone who's joined in from, again, overseas as well as in Papua New Guinea. We've got some pictures of our staff who are, we've got some pictures of our staff in Goroka in the Adult Saweri Lecture Theatre, at the Molecular Hub in Port Moresby at the Medical School, and our Madang IMR staff are viewing from Madang Resort. So thank you, everyone. We really acknowledge your participation. Thank you. The chat's been hot, lots of comments and positive comments about the research work we've been doing, as well as some great questions. And we appreciate all the staff who've actually hopped on to answer some of those questions because we've had to keep the schedule and keep the show running essentially. So thank you for that. I also want to acknowledge research partners who tuned in from overseas. Got collaborators from JCU, the Kirby Institute, UNSW in New South Wales, the Menzies, Burnett, and also partners at DFAT. So thank you. And we have some partners who are actually tuning in from Bangkok. So thank you to everybody. So we are now going to get to our final spotlight session on innovators. And it's my great pleasure to introduce my colleague, Mr. Barne Willie. Barne is actually a PhD candidate down at the University of Queensland in Brisbane, and his spotlight is focused on the work that he's doing with Neisseria gonorrhoeae. So thank you, Barne.
Hello, everyone. I am Mr. Barne Willie, attached with the Sexual and Reproductive Health Unit at the Papua New Guinea Institute of Medical Research. I am currently in Associate Professor David Wiley's lab at the University of Queensland Centre for Clinical Research for study. My research is focused on Neisseria gonorrhoeae antimicrobial resistance. Antimicrobial resistance is a global public health threat and concern because many human pathogens have developed resistance to all the antibiotics that were used in treating them, and Neisseria gonorrhoeae is one of them. Given the public health threat of antimicrobial resistance, the World Health Organization and other regulating bodies recommended that resistance surveillance must be done on a regular basis to ensure that the efficacy of the primary treatment is maintained above 95%. And if resistance above 5% is observed, then a change in treatment must be considered. In terms of Neisseria gonorrhoeae management, Papua New Guinea is among the only 3 countries in the Western Pacific region where the treatment of gonorrhea is still based on amoxicillin. However, this may change for Papua New Guinea, where in the new treatment guideline, cephalosporin, which is the last remaining drug of choice, was recommended as the primary treatment. But importantly, Papua New Guinea left an up-to-date resistance surveillance data to appropriately inform this change. In that light, as part of my research project, I am using a novel approach by molecular assay to test for the presence of genes and gene mutations in Neisseria gonorrhoeae that are associated with resistance to the main classes of antibiotics, namely penicillin, tetracycline, quinolone, and cephalosporin, to fill this local resistance surveillance gap. To note, culture method remains the gold standard method for resistance testing, especially for Neisseria gonorrhoeae. But the main downside of its use is the use of live bacteria, which requires stringent conditions of handling and transportation, which subsequently increase cost of testing. On the contrary, molecular testing does not require stringent conditions. Therefore, its use can easily and quickly enhance resistance surveillance, and importantly, provide an up-to-date resistance prevalence data. This can benefit in informing and guiding health policies in management of sexually transmitted infection, in our case gonorrhea, which can improve antimicrobial stewardship, and guide spending on the different antibiotics for use based on local needs. Further, those data can help guide future research and surveillance. Well, my research would not be without the support from the Papua New Guinea Institute of Medical Research, the Australian Award Scholarship, and the guidance from my advisory team, the permission to use archive samples by the principal investigators of one-time and IBBS study, and many others who were involved. Thank you.
Thank you, everyone. Thank you for staying up with us. This is our last session now. Session 4, looking at responding to the pandemic, research on COVID-19. I know we're all tired of talking about COVID-19 after a long 2 years. But we at the IMR would like to take this opportunity to thank the Buttressing coalition that enabled some of our scientists to do small research projects on COVID-19, and this enabled them to win small grants and to help them to build their careers as scientists. And so we are privileged to have 3 of those talks today. Dagvin Swarkia will be talking about the use of saliva for diagnosing COVID-19 in PNG. This will be followed by Tamara's talk on genetic analysis of SARS-CoV-2 with particular attention on the Delta variant and its association with human genome variations in Papua New Guinea. And Alice will be talking about the work that she's been doing. This work was particularly supported by WHO, look at preliminary findings from mixed method assessment of the impact of the response of COVID-19, particularly to health service provision in Papua New Guinea. Thank you.
Hello, my name is Dagwin Sorkia. It is my pleasure on behalf of our study team to present results of a small study we conducted earlier this year to assess the potential of saliva as opposed to the nasopharyngeal swab sample for the diagnosis of COVID-19 in Papua New Guinea. The sudden emergence and global expansion of COVID-19 and emergent strains has highlighted a need for a test method that is not only sensitive and specific, but also rapid to facilitate timely results and interventions. For developing countries, these methods need to be practical in terms of availability, simplicity, and affordability, etc., to be useful. Although nasopharyngeal swab samples is the first choice material used for the diagnosis of COVID-19, it has certain disadvantages. Among other things, obtaining nasopharyngeal swab is invasive. It causes anxiety and discomfort, and sample quality can be compromised because of that. In Papua New Guinea, a major challenge was faced following widespread reluctance to test because of its invasive nature. In addition, consumables and reagents, including universal transport media, used at the time were not readily available due to global demands at the time. Advantages of saliva is that it is essentially a ready sample, and collecting it causes less or no stress, and it is safer. Also, because it can be collected in abundance, it guarantees more flexibility in its use compared to the nasopharyngeal swab sample. Many studies elsewhere have found that saliva can be used as an alternative source material for the diagnosis of COVID-19, and in some cases, it has proved to be more sensitive than the NPS sample. The SARS-CoV virus can be set into the saliva and the oropharynx from the upper and the lower respiratory tract, from the salivary glands and the duct, and also from the occasional blood that spills into the oropharynx cavity. Moreover, the presence of SARS-CoV host receptors like ACE2 and TM proteases in the epithelial and the squamous cells in the oropharynx demonstrates that the potential for COVID virus to replicate and grow at the site. For this study, we also presume that being from a nutrient-rich site, saliva would provide a rich environment with essential micronutrients that would sustain the microbes as it is. And the aim of this study was to establish that saliva could be a viable alternative for COVID diagnosis in Papua New Guinea, and also to simulate supply issues faced during the pandemic. We wanted to show that diagnosis can be achieved without collecting samples in the UTM media. The study was conducted at the Goroka Provincial Hospital, at the COVID Center, and also the PNGIMR clinic. Patients were recruited following informed consent. Socio-demographic and clinical data were obtained. The patients were screened using PanBio RDT, and then they were asked to roll their tongue on the inside of their cheek several times and spit 3 to 5 ml saliva into the collection tube that were provided. The corresponding nasopharyngeal swab samples were also collected from each consenting subject. All samples were analyzed using 2 different real-time PCRs. We report here the results of the Mecomic PCR from Berlin. Now, the results were available for 39 of the 72 subjects that were recruited. There were 16 males and 23 females. The age range ranging from 9 years to 70 years, with a mean age 37.9 years. All residents were from Goroka. 34 of them were symptomatic, while 5 were asymptomatic. The duration of those who were healed prior to collection of the sample and prior to testing were 3 days and 4 days respectively. In the patients that we recruited, we found cough, followed by fever, headache, sore throat, runny nose, and muscle ache to be common signs and symptoms. Loss of taste, smell, fatigue, and red eyes were also not common in these patients. The SARS-CoV-2 virus was detected in 76.9% of collected saliva, compared to 77.4% and 71% detected respectively in MEDS, NPS, PCR, and the corresponding RDT. The detection limits using EGene PCR for both saliva and the NPS samples were found to be comparable, as shown in the CT plot. The differences between them were not significant. This continued to be true also for the detection using the SARS-CoV-2 specific RT-PCR, the detection limits shown by the nasopharyngeal swab sample and saliva samples were also found not to be significantly different from each other. We went on to use RDT positivity and clinical signs and symptoms as reference to determine performance of saliva and nasopharyngeal swab PCR. Saliva PCR was found to give a more concordant result overall than NPS PCR. The test sensitivity, specificity, the positive and the negative predictive values as shown here were seen to be slightly superior with saliva than with NPS. In conclusion, we found that saliva can be a viable option for COVID-19 diagnosis in Papua New Guinea in suspected outbreak situation. We also found that saliva as a potential nutrient-rich source can be able to keep the SARS-CoV-2 virus viable for detection without a need for UTM. We detected the virus consistently in samples that were followed for 7 to 8 days. The results were not included in these presentations. We also found that the virus could still be detected when kept over a month. Saliva also provides a less costly means and practical option for COVID-19 diagnosis in resource-limited settings like Papua New Guinea. We determined greater concordance between the PNBio RDT and the clinical signs and symptoms and saliva PCR than with the nasopharyngeal swab PCR. Overall, our study shows that saliva perform better than the NPS PCR and could provide an option for future diagnosis of COVID going forward in the country. We would, in conclusion, like to thank the hardworking nurses who contributed to this study at the provincial COVID center at Goroka Provincial Hospital. We also want to thank Drs. N. Larson, Moses Laman, and Professor William Pomat for their oversight. I would also like to thank Dr. Celestine for helping me with this presentation, and also a big, huge thank you to the PNGIMR Buttressing Coalition partners to support with ICRAS funding, which made this study possible. Thank you all.
My name is Tamara. I'm a scientific officer with PNGIMR based in our PNGIMR Partnership in Health Laboratory that's located in UPNG School of Medicine and Health Sciences in Port Moresby. I am presenting on behalf of my colleagues listed who are partners of the PNG Molecular Hub. I'd like to acknowledge Mr. Willie's contribution to some of the slides presented here. This presentation is of 2 sub-studies focused on the genetic analysis of SARS-CoV-2 variants and human gene variations associated with COVID infections. Sub-study 1 is a lab-based project funded through an ICRAS grant supported by the Buttressing Coalition Fund. Our sample subset comprises of 119 samples collected during the pandemic and tested by the PNG Molecular Hub team in Port Moresby. This study is progressing. Sub-study 2 is focused on the bioinformatics analysis of 4,609 whole genome sequences of SARS-CoV-2. These sequences are publicly available on GISAID. This is progressing with a planned detailed presentation in the medical symposium next month by Mr. Willie. I will share some background on study 1 of the viral spike protein variants and human receptor variants, preliminary results of that, and then proceed to sub-study 2. When this study was proposed, PNG was not as severely affected by COVID like other nations. Questions were raised about why this was the case. Studies have shown that the spike protein, red in the picture on the right, binds to the human ACE2 receptor in blue like a lock and key. The temperase protease cleaves the proteins that are binded, allowing fusion of the virus into the cell. Studies also suggest that these receptors and proteins influence severity of the disease. Therefore, genetic polymorphisms in these human genes will help us to understand the trends of severity of COVID in PNG. Data on variations of these genes in PNG is lacking. This data is not only important to understand the trends experienced in COVID, but it will also provide data on the polymorphisms of these genes in Papua New Guinea. Other normal functions of the human ACE2 and TMPRSS genes are associated with the regulation of blood pressure, wound healing, and inflammation. Due to my limited time, I will not go through the methods in detail. 119 samples were collected from 7 provinces. In PNG is shown in the map below. Human genotyping is still progressing. Viral genotyping is progressing for 80% of the samples. 20% of the samples have whole genome sequence data available, with numbers shown by this graph. The 20% represents 24 samples from 4 sites. Delta was more widely spread in other sites, with Port Moresby in the National Capital District having all the Omicron cases for our sample set. Sub-study 2 was of the genetic analysis of SARS-CoV-2 Delta variants in PNG. Data was extracted from the GISAID server. To date, there are more than 12 million whole genome sequences available on GISAID. PNG has 4,609 sequences for strains that were in circulation in PNG. I'd like to acknowledge the National Control Center for COVID-19 and the Central Public Health Laboratory Surveillance Unit for the massive effort in coordinating samples from across the country to Doherty Institute in Australia to enable these sequences to be available. I'd also like to acknowledge Australian DFAT for funding the testing. The 4,609 whole genome sequences available were analyzed using the Genius Prime software. I will share preliminary and brief results. Detailed results will be shared later. We focus on the Delta variant due to its virulence and predominance in PNG. The Delta variant was first identified in India in October of 2020, and it was the most contagious variant worldwide, spreading faster than the original strain. The Delta variant is defined by mutations in the virus's spike protein. This diagram illustrates how the mutations in the spike protein are in the terminal domain, the receptor binding domain, and the receptor's binding motif. Using the Genius software, we were able to analyze in detailed point mutations of SARS-CoV-2 strains in PNG. The reference genome of the Wuhan strain from PubMed's GeneBank was used. Sequences were aligned against this reference. Disagreements to the reference sequence, known as single nucleotide polymorphisms, can be seen as shown. Deletions in the sequences can be seen as shown. Insertions in the sequences can be seen as shown. Undefined regions, as shown here, were excluded from the analysis. Genius is also then able to convert the DNA sequences into protein sequences to determine the differences in circulating variants of concerns or strains in our sample set. The whole genome sequence data available represents 10% of the reported cases in PNG. We were able to align 95% of the sequences available. No other variant of concern was detected except for Delta and Omicron. There were 4 clusters observed, the green cluster 1 being the wild type Wuhan strain. Cluster 2 was the D614G. In blue, it does not belong to a variant of concern group, but was just as prevalent in circulation as Delta and more infective than the wild type Wuhan strain. 13% of the sequences were Omicron, 41% were the Delta variant. As I have mentioned, a detailed analysis will be presented during next month's symposium. I would like to acknowledge the funders of this study, the Buttressing Coalition Fund and Australia's DFAT, coordinating partners in country, the NCC for COVID and CPHL Surveillance Unit, and partners of the PNG Molecular Hub from PNGIMR, School of Medicine and Health Sciences of UPNG, Central Public Health Laboratory, and Barne Institute. Thank you.
Hi, I'm Alice Mengi. I'm a research fellow in the Sexual and Reproductive Health Unit at the PNGIMR. On behalf of our project team, I will be presenting preliminary findings from a mixed method assessment of the impacts of and responses to COVID-19 within primary health and infectious disease programs in Papua New Guinea. Our team of investigators included the PNGIMR, the Kirby Institute from the University of New South Wales, the Barne Institute, and the World Health Organization. I'd also like to make mention of our incredible field teams who collected all of this important information, teams from both the PNGIMR and the Barne Institute. To provide a little bit of scope for the study, our research aims included to evaluate the impacts of COVID-19 on health service provision, to assess the impacts of COVID-19 on patient and community engagement, to document the locally led health system responses to mitigate the impacts of COVID-19 on service provision, to examine patient and community initiated strategies used to mitigate access to health services, and also to evaluate the ongoing requirement for sustained access to primary and public health infectious disease programs in PNG. So as earlier mentioned, this was a mixed method study across 7 provinces. In each of the provincial sites, 2 health facilities were identified, and fieldwork was conducted between July to November in 2021. Qualitative component involved semi-structured in-depth interviews, it involved a photo voice component, and also field observations. The quantitative component of this study involved a health system survey at each of the identified health facilities. Just to provide a little bit of scope for the qualitative component of this research, 131 interviews were conducted across 7 provinces, and this also involved our key informant interviews. So in order to explore the impact of COVID-19 on the public and primary health care in PNG, we used the WHO building blocks as shown in this diagram. Some of our preliminary findings for each of the blocks includes around governance and decision making during the time of COVID, health information and health information reporting systems, finance and financial administration, the impact on service delivery, impacts on human resources or the healthcare workforce, supply of essential medicines in medicines and technologies, and of course the impact on the people who interact, engage with our health service, our community. So in today's presentation, we're going to provide a brief description of 3 COVID-19 preliminary findings from the qualitative component of this study, reporting on factors that directly influence client engagement and/or disengagement with health and health services. So these included a fear of COVID-19 infection, particularly in healthcare settings, fear of COVID-19 testing, and a fear of COVID-19 vaccination. While there were differing perceptions about the seriousness of COVID-19 in different settings, clients were more likely to report a fear of COVID-19 infection in healthcare settings. This fear was described in terms of fear of COVID-19 infection generally, fear of infection in healthcare workers, fear of COVID-19 on transport required to travel to and from healthcare services, and a fear of meeting clients at the healthcare service who may have COVID-19. This fear resulted in service avoidance by clients, which had direct impacts on the continuity of testing, treatment, and care for HIV, TB, malaria, and mother and child health. Another common practice that was spoken of by clients was avoiding health services because of COVID-19 testing. This avoidance was not necessarily a fear of COVID-19 infection or of COVID-19 testing process, but rather an avoidance practice because of a fear of testing positive for COVID-19 and then having to go into isolation if positive. Isolation where people would have no contact with others and where you would be left alone to die. So healthcare workers and parents spoke of actively avoiding healthcare services and outreach programs for the fear of themselves or their children being forced to be vaccinated. This avoidance had a significant impact on our childhood vaccination programs, with a common theme of running away from services and vaccination teams because of a belief that they would be forced into being vaccinated for COVID-19. Speaking on engagement of services during COVID, both healthcare workers and clients spoke of avoidance of services due to fear of forced vaccination at health facilities and through outreach programs. Fear of the efficacy and safety of the COVID-19 vaccine due to receiving incomplete or inadequate information, hearing rumor, gossip, conspiracy, misinformation and disinformation, all of which contributed to particular beliefs about COVID-19 generally and also about the COVID-19 vaccine specifically. As reported in the previous slide, these fears also greatly impacted our routine childhood immunisation programs. So the research team is currently in the process of completing the final report, which will expand our understandings of the impact of COVID-19 on public and primary healthcare in PNG across the diverse WHO building blocks that were identified earlier. These findings will present a more complete picture of the impact of COVID-19 on malaria, HIV, TB, and mother and child health programs in PNG. Today, we have presented a snapshot of a smaller section of the findings from this study that is focused on the impact of COVID-19 on clients' willingness to engage and or disengage with health services. But across the study findings, preparedness was a critical factor. Preparedness to deal with COVID-19, preparedness to deal with future pandemics and disaster planning, and preparedness for the health system as a whole. In closing, we'd like to acknowledge the World Health Organization for funding this important project. We'd like to acknowledge the provincial health authorities, healthcare workers, clients, and community members who gave their time to this research, particularly during a pandemic. To the research team members from the PNGIMR, the Kirby Institute, and the Barne Institute. I also want to acknowledge in this space the work of the Sexual and Reproductive Health Unit for processing all of this important data, to the PNGIMR teams at our Sentinel sites for their support while we were out during fieldwork, particularly in East New Britain, Port Moresby and Madang, to Burnett teams in Western Province, in East New Britain, in Morabay and Port Moresby for their support during fieldwork, and to all our broader research networks and partners across each of our sites. Thank you.
Thank you. We're now heading towards the final sessions for today, or the end of this program. Before we do that, I'd like to introduce to you Dr. Stephanie Williams, who is Australian Ambassador for Regional Health Security and a public health physician and epidemiologist. She's a very good friend of the Institute and would like her to say a few words about research and its use in knowledge and in ensuring that it improves health around in Papua New Guinea as well as globally. Over to you, Stephanie.
Thanks so much for the introduction. And I had a quick chance behind the curtains here to hear the degree of engagement that this symposium today has generated, both with up to 250 or more people online and a wild chat, according to Pamela, in terms of the degree of engagement with the presentations, and the value of the symposium today really speaks for itself. I think when we think about research capacity as a critical element of health systems, PNGIMR is a standout institution in that sense. Very early on, I mean, we've always supported research as part of as a partner in health, but increasingly it's becoming more explicit. In the first phase of Australia's Health Security Initiative, one of the very first projects was a Health Systems for Health Security research round, recognising that the power and the relevance of knowledge generation in country to answer the questions in country that need answering. Part of that explicit focus on research, as Prof said, has been a long-term partnership with the PNG Institute of Medical Research, and the symposium today has just demonstrates that institution going from strength to strength, not just the breadth of the presentations, but just the recent publication history and some of the researcher achievements from Lancet to Nature to BMC infectious diseases across vector-borne, sexual and reproductive health units. It's just terrific to have this moment today to celebrate the power of a growing and reputable research institution in PNG and the network of partners and support that the institution has gathered around itself over its lifetime. And we're really proud to be a partner in that from the Centre for Health Security and from Australia. So congratulations to everybody that was involved today, and yeah, terrific achievement. Thanks for the opportunity to join.
Thank you, Dr. Williams. Thank you very much for those kind words. And as we are now heading to the end of our presentation, I want to also thank everyone who's taken part in this symposium. To all the presenters who took time, I'm sure that many of you stayed up late last night or a few nights in a row to get your presentations done, and especially those young scientists who did the pre-recording. You've done a marvelous job and you've done the Institute proud, so I'd like to thank each and every one of you. I want to also thank all the staff around the country who have tried their best to access this symposium and have done so. Thank you very much for doing that. Also being able to see the range of work that we do across different things. Many of us are so focused or so siloed in the work that we do that we don't know that the Institute conducts a broad variety of research into many diseases and also the health system. I appreciate the Buttressing Coalition. You've been wonderful to us. Some of the infrastructure developments that we're currently seeing comes from the funding that we receive from you. In particular, the Center for Health Security for supporting us to get funding to help us ensure that this sort of facility, the video conferencing facility and all that, the IT system can work so that we can interact with you. And I think COVID-19 came along and restricted a lot of us from moving around, but these innovations in teleconferencing is able to then allow us to meet other people while staying where we are. So, and the Buttressing Coalition funding has really helped us to upgrade our IT system. We hope that this will be done across all the sites so that all our staff can attend the next teleconferencing that we conduct. I'd like to also thank Anne. She's done a great job. I know it's been very stressful, especially early this morning, and when we had some cancellations and all of that, and it can be that stressful. So thank you very much, Anne, for your time, and especially for taking time out in what you're supposed to be on holidays, but you're helping us with this. Dean and your team, thank you very much for making sure that going from one presentation to the next, live presentations to live to recordings, the seamless effort in going between those has been really good. So thank you very much for your hard work in making sure that that happens and for continuing to assist us with that. So with that, I want to also thank everybody in the background who's been making sure that your chats are attended to, making sure that after I get off here, I'm aware of what's going on. Also, to everyone that's joined, I'm sure that all of you are very busy individuals. Some of you might be missing your sleep because you're supposed to be asleep and you've joined us to listen to what we're saying. So thank you very much for all of that, for your attendance, for the time that you put in to come and join us, and for the comments that you've made. And hopefully together, all of you and us here at the Institute will continue to make sure that the research conducted at the Institute continues to inform knowledge, plus lead to health outcomes that will help not only Papua New Guineans, but the global audience as well. So with that, I'd like to say thank you very much to everyone for your participation. Thank you, True.